Good morning, everyone. It's 8 a.m. in Denver, Colorado, and the International Center for Colorectal and Urogenital Care at Children's Hospital Colorado, together with the Hendren Project, would like to welcome you to this bowel management course. We, as a team, feel that education is very important. That's the only way we can truly improve colorectal care around the world. And although we are surgeons, we have realized over the years that without offering bowel management, we truly don't do much for patients. So having the right operation, but not following patients and making sure they are cleaning the underwear, our job is not done. So on behalf of our entire team, we would like to welcome you. I just want to hear a confirmation that the Spanish room is working and that I don't have to wait to proceed with this meeting today. Anyone can just tell me if the Spanish room is working well and if we can proceed. I'm not hearing from anyone. Ray or Dr. De La Torre, can you hear me? Can you just tell me if everything is going well?
I can hear the English.
Okay, I'm gonna proceed because I haven't heard, so I'm assuming there are no problems.
I'm not listening the Spanish room. I mean, I am in the Spanish room, but I don't hear anything.
Okay, so we're gonna give 2 minutes just to see what's going on with the interpreters and if the Spanish room is going well.
Ahora ya estoy escuchando al canal de español y se oye bien.
Perfect. Okay, so we got the okay that the Spanish room is working. So today we have participants from Dominican Republic, Pakistan, Kosovo, Sudan, Saudi Arabia, Hungary, Egypt, India, Kazakhstan, Bangladesh, Libya, Iraq, Russia, Malaysia, Algeria, Barbados, Qatar, Uzbekistan, Canada, Colombia, Chile, UK, Vietnam, Slovenia. I think I got most of you. Lithuania, South Africa, Brazil. So I apologize. At the end, I'm gonna acknowledge all the countries again. I'm gonna start by sharing my screen. So just bear with me. Perfect. So we're going to start. My name is Dr. Andrea Bischoff, and we're going to start with what is bowel management and which patients benefit from this program. So bowel management is a generic name. It means that we will find an individualized way to provoke a bowel movement daily, at the toilet, and at adequate times. The main goal is that we want our patients to be in clean underwear without unpredictable stool accidents. There are different types of bowel management. There are different things we can offer. For some patients, they may just need scheduled meals and fiber to bulk the stool, to give the stool the right consistency. Other patients that have a very slow bowel will need to speed up that bowel, and we do that with laxatives, with stimulant laxatives. Other patients that have no bowel control, they will need a daily enema. Enema is when we put a solution inside the rectum. The patient evacuates immediately after that. Other patients, we need to slow down the colon, and there's a medication called loperamide or Imodium that slows down the colon. And other patients may need daily enemas, and Imodium. The type of bowel management that we offer for each patient will depend on the diagnosis of the patient. Which patients benefit from the program? The first large group of patients are patients born with anorectal malformations, also known as imperforate anus. And when we think about anorectal malformation, we must remind that we are talking about a spectrum of disease. There are benign diseases that carry a good prognosis for bowel control. Those patients suffer from the worst type of constipation and they will need bowel management with laxatives. There are patients in between that they have borderline bowel control. Sometimes they make it to the toilet, sometimes they don't. And then there are patients in the worst side of the spectrum that suffer from fecal incontinence. And those are the patients that will need enemas. So here's an example of different types of anorectal malformation. We are seeing the image of the perineum of the bottom of a baby boy. And here we can see a tiny opening. That's the rectoperineal fistula. When this malformation has a normal sacrum and receives a good operation, patients have bowel control, but they suffer from constipation. Now we are looking at what we assume is an imperforate anus because we don't see the opening of the anus. But we still see a good midline groove, a good anal impression. So this could be, for example, a rectourethral-bulbar fistula that carries a good prognosis for bowel control, about 85% chances. Again, patients with good prognosis, they suffer from the worst constipation. Now we are looking at the bottom of a female patient and we can see the urethra, the vagina, and here is the vestibular fistula opening in the vestibule of the vagina. This is a malformation that has good prognosis for bowel control, about 95% chance of bowel control. In this case, it's a little girl that instead of seeing the three holes, urethra, vagina, and anus, we are just seeing one single hole. That's the diagnosis of a cloaca. And in cloaca patients, the length of the common channel will impact the chance of having or not having bowel control. When we have a short common channel with a normal sacrum, we have about 70% chance of bowel control. And now we are seeing the bottom, the baby is face down, and we are seeing what we call a flat bottom. We don't see a good midline groove, and the center of the sphincter is close to the base of the scrotum. So this baby is probably born with a rectal bladder neck fistula, which is the highest type of anorectal malformations in male patients, and these patients suffer from fecal incontinence. Again, quality of the operation and the quality of sacrum together with the type of malformation is what determines where the patient will be in terms of bowel control. But this is an information that the parents should know. We physicians should tell the families about the future prognosis for bowel control. The other condition that comes to us for bowel management are patients born with Hirschsprung disease. And there are different types. Again, it's also a spectrum. But in Hirschsprung disease, what happens is the bowel is doesn't have ganglion cells in the most distal portion. It can be the most common one that is just in the rectal sigmoid. It can be a long segment that goes all the way to the left and transverse colon, or it can be the entire colon. Patients with Hirschsprung disease, different than patients with anorectal malformation, they are born with a normal anus. So they are born with bowel control. Now, unfortunately, the surgery can be done incorrect and damage the anal canal. That's the area where the sensation is to feel the bowel movement. So if the operation damaged the anal canal, these patients will be fecal incontinent and will need enemas. Now, if the patient was done correct, some of them may suffer from constipation and may need laxatives. The other large group of patients that we treat are patients with what we call idiopathic constipation. Idiopathic, the word means we don't know what causes. Constipation is the most common problem on earth. We just know these patients don't have bowel movements every day. They suffer from fecal infection and they need laxatives to empty their bowel properly. The other large group of patients are born with spina bifida, and these patients, majority of them will suffer from fecal incontinence. Other group of patients, they are born with absent sacrum. It's a spectrum. These images didn't come out good, but in this case, you can see this is what we call the iliac bone. So in this case, the iliac bones are fused. There is absolutely no sacrum. So these patients suffer from fecal incontinence and they also cannot walk. And there is a spectrum of how many bones you are missing in the sacrum. But whenever you have nothing below the sacroiliac junction, those patients will be fecally incontinent too. And the other group are patients that are born with sacrococcygeal teratoma. Nowadays, those large sacrococcygeal teratomas, they are diagnosed in utero, and those patients also will suffer from fecal incontinence. When to start formal bowel management? We want our patients and all this population that I mentioned to be out of diapers at the same age that other children are out of diapers. In the United States, the deadline when you have to meet this criteria is when the child is entering kindergarten. So we like to say it's between 3 and 5 years of age. We want our patients to be in underwear at the same time that other children are in underwear. But in some cases, we need to start bowel management sooner. When they are babies, we want to try to establish regularity. We want to avoid diaper rash and avoid severe constipation. So for some babies, we have to start bowel management sooner. Again, 0 to 3 years of age, we're trying to establish regularity, avoid and treat constipation, avoid and treat diaper rash. So now let's see an example. This is a 4 years old male patient, toilet trained for urine, that it's unable to feel when he passes hard stool in the underwear. So this is a patient that probably suffers from constipation and will benefit from bowel management. Another example, a 5 years old female patient successfully toilet trained for urine and stool and now is having stool and urinary accidents. That's probably a child that is suffering from constipation. This patient will benefit from bowel management. Another example, 5 years old, male patient born and operated for anorectal malformation, successfully toilet trained for urine, unable to toilet train for stool. So we'll have to see this patient, determine if he has potential for bowel control or not, but most likely this patient will benefit from enemas. Another example, 5 years old, female patient born and operated due to Hirschsprung disease, successfully toilet trained for urine, unable to toilet train for stool. In patients with Hirschsprung, we are going to examine the anal canal to determine the potential for bowel control. If the anal canal is damaged, this patient will benefit for enemas. If you're in doubt, call us. We can tell you if your child or if your patient will benefit from bowel management. So I am happy to answer questions, and I'll ask Dr. Luis de la Torre to help me with the chat. And I'm going to stop sharing my screen. So is there any questions? Are there different kinds of rectovestibular, for example, complex and non-complex? So yes, there are different types of rectovestibular. And what we name the type of malformation rectovestibular, and what adds complexity to the care of the patient is the quality of the sacrum, if the patient has associated urinary anomalies, associated cardiac anomalies, but the type of the rectovestibular fistula, I would say, is the same. If the patient has absent vagina is another example. What percentage of the patient population have idiopathic constipation? I don't think we know these numbers. We just know that constipation is the most common condition in the world, and I think it has to do with our habits. In the past, we used to hunt and we had to exercise a lot to get our food, and nowadays we have the luxury of just sitting down, calling, and having food delivered to us. So I think our habits have made constipation worse. At what point would you decide to do them alone? That we're going to discuss in the next lecture. I think I answered all my questions, and I'm going to invite our next speaker, that is Dr. Luis de la Torre, to tell us why is the abdominal radiograph crucial for a successful bowel management, and why is the contrast enema important. Welcome, Dr. de la Torre.
Hello, everyone. Good morning. I want to explain you why in bowel management is crucial, is very important to obtain abdominal x-rays and to have a study that we call contrast enema before we start this bowel management program. So the goals during this bowel management for patients that suffer in fecal incontinence, as you can see in this slide, is to produce a predictable bowel movement to clean the colon, sigmoid, and left colon, and obviously to stop involuntary bowel movements or poop accidents. When we treat patients with constipation, the goal is to produce one bowel movement every 24 hours to clean, again, clean the rectum, sigmoid, and ideally the left colon, and obviously to avoid fecal impaction and involuntary bowel movements due to overflow. So why is it so important to take an abdominal x-ray during the bowel management program or when the patient is being treated with these conditions? Well, because the only way to do a good monitoring, we need to monitor these patients to be sure that the treatment is working. If you are using insulin because you have diabetes, then you need to take sometimes blood tests to confirm that your blood sugar levels are in the right range. If you suffer hypertension, okay, you can take the blood pressure 1, 2, 3 times a day. Another way to monitor our health is the temperature. Patients with prostatic problems, they can do PCA test. So doctors need to monitor treatments. The problem that we have seen for the last 30 years is that most or many bowel management programs, they do not monitor their patients. And the only way to monitor patients with or on bowel management is with radiologic monitoring or x-rays. If you want to have a successful bowel management program, one of the key portion of this is the radiological evaluation. And the most important is to remember the timing for the x-ray is very, very important. This is the rectum and this is the sigmoid, and they are the natural reservoirs for poop. So when the colon starts to work, we are going to collect the poop on this one, and then the patient is going to have a bowel movement. This is the perfect time to take the x-ray, no 1 hour or 7 hours or 12 hours after a bowel movement. When we look at the x-ray, it is important just to be focused on the rectum, the sigmoid, and the left colon. This is the rectum right here. The sigmoid could be here, and this is the left colon. In this radiograph, you can see some stool seated in the rectum, and this x-ray was obtained after a big bowel movement. That means the patient needs more bowel management, more laxatives or more enema. It depends what we are doing with this patient. So the x-ray is the most important. But look, on the right side of the patient, left side of your screen is the right side of the patient. This is the right colon. Always we have poop in the right colon. So when a radiologist read this x-ray, is going to say there is a large amount of stool in the colon. Yeah, but the colon has many segments. So how to read an x-ray in a bowel management program? You need to do a line like this one, okay? And you need to look for poop on this area. Now, on this slide I think it's more clear. We don't want to see the poop on the right side of the patient or on the left side of the screen. The most important is this area, because always we will have poop here. Remember, this is very, very important. When you have a patient with severe constipation, a lot of poop, even though you can do the line and you will see a lot of poop on the right column, but also on the left. Remember, this is our goal. When you have a patient like this, you don't need to do the line. You already know that all the left colon, the rectum, and the sigmoid is full of poop. This is the same patient, but now it's clean. So you don't need to do the line because there is no poop, even though you can see a little amount of poop here. And this is very challenging because sometimes radiologists without experience looking x-rays in bowel management, they will describe there is residual stool in the abdominal x-ray. Yes, of course, but it's in the cecum, it's in the right colon. And we are going to talk about more about this. When should the abdominal x-ray be taken? Immediately after a bowel movement in patients on laxative or in patients with enema after the enema. The process of the enema lasts usually 1 hour. So after the enema is done is the perfect time to take the x-ray. Why is it essential to perform a contrast enema before starting a bowel management? Why we need to do this test? Well, number one is because very important to know the anatomy of the colon. All the patients with Hirschsprung, patients with anorectal malformation, patients with idiopathic constipation, and patients with neurogenic bowel, they have different anatomy. Some have already many surgeries. Some have very short colon. Some have huge rectums. Some have very small rectums. And remember, the rectum and the sigmoid are the natural reservoir. All the patients with Hirschsprung, they lost this reservoir. So it's very important to know the anatomy and to determine the size of the rectosigmoid. This is a normal anatomy of the colon. On the left side of the screen, you can see this dilated colon, which is normal, which is the right colon. This is the normal anatomy of the right colon, is more dilated compared with the left side. So this is a completely normal right colon. Right here is the appendix. Then the transverse colon, because the colon crossed from the right side to the left. The left colon, or descending, because the poop goes from above to down, so descending, the poop moves from here to here. Descending or left colon is this one, and this is the normal anatomy. These indentations that you can see here in all the colon or the large bowel, we call this haustra, and that's normal. When the colon lost this indentation, something is wrong. And then you will have here a loop or a couple of loops of bowel that we call the sigmoid. And then in the pelvis is the rectum. So again, the right colon, transverse, left, sigmoid, and rectum. Now, it is important to know that always the right colon is going to have poop after a bowel movement with enemas or with laxatives. So remember, don't be afraid to look poop on this side. Wow, this is a different contrast enema, right? Because you cannot distinguish, you cannot determine where is the cecum. The cecum is the initial portion of the right colon. So where is it? Wow, we can say probably this is the transverse, this is the right, this is the left probably, this is the sigmoid. And here in the pelvis, share this space, both the cecum or the initial portion of the right colon and the rectum, and they overlap. When you have this type of contrast enema, probably you can have some issues when you read the x-ray after a bowel movement. Because if the patient has a good bowel movement, good enema, and is clean the rectum, the sigmoid, you will see some poop because the sigmoid is behind the rectum. And this is the patient. This patient is the same. This patient is before, look, he has a balloon here. Then we remove the balloon and send the patient to have a bowel movement. This is after he had a bowel movement. That's why we call the post-evac. And you don't see what happened here. There is contrast in the rectum and there is contrast in the cecum. These patients, you need to know that if you are doing bowel management, probably you can see some image of poop, but usually is the cecum. This is tricky, but it's important to remember. The other goal of the contrast enema is the size of the rectum. This is a gigantic rectum. The rectum is a pelvic organ, and the pelvis is this area. This rim is the pelvis, okay? But now the rectum is outside the pelvis, is reaching almost above the belly button. This is a very dilated and enlarged rectum. If this patient suffers constipation, the treatment will be different compared with the next one. This one has a almost normal or small rectum. Both patients suffer constipation, so the treatment will be different between this patient with this huge rectum and this rectum. That's why it's very important to do the contrast enema. In 2023, we published a study of patients that came to the colorectal center for idiopathic constipation, chronic idiopathic constipation, which is the most common problem in our center among patients with hyperforidinous and Hirschsprung. I'm just going to explain you very fast what we did. We collect 80 consecutive patients with idiopathic constipation. Patients with treatment before that we call radiologically supervised bowel management program. So before they came, these patients had non-treatment. Most of them, they got polyethylene glycol, enemas, Senna, Botox, already have 5 surgeries to produce an ACO Malone, and one patient had a sigmoidectomy, which is a resection. None of these 80 patients had previously an abdominal x-ray to monitor the treatment of this constipation. Then we collect these 80 patients and enter to our program that we call radiologically supervised bowel management program. After a week with this radiologically supervised bowel management program, 73% of the patients were clean and we were successful with Senna, in other words, with laxatives. And 21%, 27%, 21 patients just with enemas. So this is very, very important. Remember, these 80 patients had unsuccessful bowel management, unsuccessful with all this treatment. What is the key in this program was the x-ray, because we treat these patients monitoring every day with an x-ray. You can read the complete paper in this reference. Thank you very much. If you have any questions, you can send me an email to luis.delatorre@Children's Colorado, or in Spanish, en español, hirschsprung@gmail, or cirugía.pediatrica@mac.com. If you have any question, let me know. If not, we can continue.
Thank you, Dr. De La Torre. So I'm going to move on so we stay on time. And let me just share my screen. So now we're going to discuss briefly what is bowel control and what is fecal incontinence. So bowel control means that you can feel sensation, so you know that it's something is coming, either gas, liquid, or stool. You can hold, meaning you can delay the bowel movement. I'm giving a lecture, that's not the appropriate time. I'm going to go later. You can make it to the toilet, not because you're a fast runner, because you can hold it and your underwear is clean. That's the definition of bowel control. And examples in real life, it means you're in a drive, you're in a family road trip, and suddenly one of the child says, I need to go to the bathroom. But as you know, there are not bathrooms available everywhere. So we're going to start looking for a bathroom. And during the process of looking for the bathroom, the child can hold and wait until is appropriate. The other example, the child is at school, and many of our patients, they have accommodations in which they can go to the bathroom as needed, but we want them to be able to wait. And if it's an important teaching moment, they can ask for permission, wait until permission is granted, and then make it to the toilet. So those would be examples of bowel control. Now, on the other hand, what is fecal incontinence? It's exactly the opposite. You can't feel, you don't know how to differentiate when it's gas, when it's liquid, when it's stool. You can't hold. When you have to go immediately. You can't make it to the toilet unless you are at home, very close to the toilet, and your underwear is not clean. So when we're talking bowel management language, we call accidents when you pass stool in the underwear at an unpredictable time. So you can have fecal incontinence, no bowel control, and a slow motility colon. That's what we call hypomotility. You can also have fecal incontinence, no bowel control, and a colon that moves very fast, tendency to diarrhea. This is what we call hypermotility. Many people only think of fecal incontinence as constantly passing stool. That's not the case. There are patients that are very constipated, mean they will pass stool every 3 days, but when they pass, they don't feel. So they are fecal incontinent with tendency to constipation. Or they can be fecal incontinent with tendency to diarrhea. The most common scenario is fecal incontinence with tendency to constipation. Now, bowel control is not 0 or 100%. Even the normal population that has bowel control sometimes may fail. And I don't know if you have heard of El Mal de Moctezuma. It's very famous for when you travel to Mexico and then you get a terrible diarrhea, and most people cannot make it to the toilet. So, understanding that bowel control is not 0 nor 100% is important. So patients with anorectal malformation who have bowel control, the ones that are in the good side of the prognosis, they still need the right consistency of the stool to feel the bowel movement. We tell families that the two enemies are constipation and diarrhea. We really need the right consistency in order for those patients that don't have normal sensation to be able to feel it. Now, what do you do when you have bowel control 50% of the times? Meaning, sometimes you feel it, sometimes you don't, sometimes you make it to the toilet, sometimes you don't. This is a quality of life decision. If the stool accidents are impairing your or your child's quality or your patient's quality of life, you should start bowel management with the goal to completely avoid accidents. Let's talk about two examples. Number one, the patient is homeschooled, meaning they attend school at home, not bothered by stool accidents. And when this patient goes to do outside activities, stool accidents don't happen. So this is a patient that currently the stool accidents are not affecting his or her quality of life. Other scenario, a patient that attends regular school and also after school activities, usually sports. Stool accidents are very disturbing, and when they happen, and they are happening about 3 times a week. So this is a patient that the stool accidents are actually bothering him or her, so we should act upon them. And the other thing is, you can always try bowel management with enemas, and then you can see, is the quality of life of my child better doing the enemas, or was the quality of life of my child better having stool accidents? Bowel management, it's a quality of life decision. It's not a life or death decision, but it's important to try and judge. And in our experience, children feel much better when they are clean in the underwear. In the beginning, they do resist. They don't want, like they don't want to brush their teeth every day, or they don't want to shower. But once they start on it and they are in a routine, they enjoy being clean. And it's a myth that if you start the child on enemas, you are erasing the possibility of having voluntary bowel movements in the future. We actually feel it's the other way around. We recommend, if the child has 50% chance of bowel control, we recommend starting them on enemas around 3 years of age. Let them enjoy being clean and feel clean. And then every year during vacation, we can try to stop enemas and see if the child can achieve voluntary bowel movements. It's usually easier to transition a child that has been clean and toilet trained from urine to then move on to laxatives than a child that has been having urinary and stool accidents and has been on diaper all his or her life. So it's a myth, and that's important for parents to know. And again, there's nothing wrong in trying enemas and see how the quality of life is with enemas. So that was my short talk, and I'm happy to answer any question regarding the definition for bowel control or fecal incontinence. I'm going to stop sharing my screen and see what are the questions. My son takes enema and stays clean all day. I want to know what's next. Does he need to take all life? Is there another way to keep him clean and having bowel movements? So those are difficult questions for us to answer. We need to know what's the diagnosis of the patient, how is the sacrum, what is the potential for bowel control. And if there is potential for bowel control, then we recommend a laxative trial to see if the patient can have voluntary bowel movements. For patients that the treatment will be enemas for life, I'm going to talk in my next talk, we recommend trying independence now. Once in the beginning, parents are the ones doing enemas, but as the child grows older, we want the child to learn how to do enemas. For some patients, they learn how to do through the rectum, which is a little hard. Other patients, we do a Malone procedure that I'll talk later, that it's an antegrade enema procedure. There are many questions. Let me see here the other one. Does bowel management always consist of enema? Not always. Bowel management, as I mentioned, sometimes it's just fiber, sometimes it's just medication, sometimes it's laxatives, sometimes it's enemas. It depends on the diagnosis of the child and the potential for bowel control. My 10-year-old will now allow irrigation, suppository, or enema. He just fights. Daily stool incontinence. What are the other options? I think at 10 years old, it's important that the child has a discussion with the physician to decide what is the best for him or for her. We also have a psychologist in our team, and sometimes we have to involve the psychologist to help us determine what's best for the child. But it cannot be a daily fight, especially if it's a daily treatment. My child has rectal prolapse, will be doing peristeen nightly, make it worse. So patients with spina bifida, they have a tendency to prolapse, but we don't feel that the enemas make the prolapse worse. Of course, the more you sit in the toilet, the more you push, you tend to make the prolapse worse. But if it's one bowel movement, quick, easy, we don't think you're making it worse. I think how much of this information has been disseminated to pediatricians and gastroenterologists? The most obstacle. Well, we we can only offer the education. We cannot force people to join our web meetings. We are very open in how we share information, but there are different opinions on how to treat things. So I'm going to move on so we stay on time, and I'm going to invite Dr. Luis de la Torre to now talk about what is constipation.
So let's talk about constipation. So the question is, what is constipation? There are many definitions, many, and you can find in books, publications, Google, ChatGPT, what is constipation. But I want to introduce the concept of constipation. We don't want to do definition. We want to introduce to you the concept of what is constipation. So every patient, every human needs to clean out the rectum and the sigmoid. Remember, the rectum and the sigmoid are the natural reservoirs for poop. So we need to clean these deposits of poop every day. You produce urine 24/7, all day, all night, you produce urine, but you have a bladder, and the bladder is going to collect the urine, so you can pee 1, 2, 3, 4, 5 times a day. Same thing happens with the poop. You produce poop 24/7, and then you clean out the reservoir. The reservoir, again, is the rectum and the sigmoid. And this should be on a regular basis, every day in the morning, every day after every meal, every other day. But the goal on this regular bowel movement is that you need to clean out all the poop. You cannot leave residual poop. That's the concept. You can have daily bowel movements, but you only move 50% of the poop that was collected in this reservoir. Constipation also, again, is if you can poop 3 times per day. And you say, no, I am not constipated because I poop 3 times a day. Yes, but every time you go to the toilet, you only move 50, 20, 80% of the poop. And you are going to start to collect and collect poop. And this poop then is going to be big, dry, and very difficult to clean out. Or constipation is the lack of both regular bowel movements and incomplete elimination of stool. So this is the concept. Look, again, the rectum and the sigmoid are the natural reservoir. The poop then is going to move and be collected in this reservoir. This is a good bowel movement. You can do it 3 times a day, every other day, but the goal is after a bowel movement, the rectum and the sigmoid should be clean. When you leave residual stool, wow, look what happened. The poop now is different, right? It's big, dry. And this dry, very difficult poop, now you cannot move it out. And the only way to know if you are collecting all poop and you have fecal impaction is with an X-ray. Fecal impaction means obstruction of the intestinal tract. Usually is a partial obstruction, but sometimes it's a complete obstruction. And the patient shows a very dramatic clinical picture, and they ended up in emergency room. So fecal impaction could be chronic. We have patients with fecal impaction that is lasting for years. So they always have fecal impaction. And these patients usually have poop accidents. And the GI team, they call encopresis. And we call pseudo-fecal incontinence because these patients have fecal incontinence due to overflow. Constipation affects newborns, infants, toddlers, scholars, teenagers, and obviously adults. So constipation is the most common GI problem that we treat in this center and affects all the ages. Problems related with constipation are patients that born without anus or imperforated anus or anorectal malformation, patient that born with Hirschsprung, patient that born with spina bifida and then develop neurogenic bowel. And the most common problem again is the patient that born without any of these problems, but the patient develops constipation. And we don't know why they are constipated, and that's why we call idiopathic. Constipation is a scale or a spectrum. Not all the patients have the same severity of constipation. If we can create a scale, should be very similar to this one. From 0, that means the patient poops every day and clean out the rectum and the sigmoid every day. The number 1 is a patient that, oh, he doesn't poop every day, or she doesn't poop every day, or she start to have painful bowel movements. And then the number 10 is the patient with the most severe constipation. We received many patients that they said failed to the standard treatment. A standard treatment is a phrase that many pediatricians, GI surgeons say to the most common treatment, which is diet. They want to give some food. They're trying to use prune juice, polyethylene glycol, and many others. So the standard treatment usually helps to relieve very, very mild constipation. So in the initial scale of this treatment, patients with more severe constipation, they will need radiologically supervised medical treatment, and we will talk later about how to do this radiological supervised medical treatment for constipation. You need to have discipline with meals. You need to use stimulant laxatives, and I will show you how to use it. Some patients need enemas forever, and sometimes patients need operations. The most common problem in this side of the spectrum is patients with fecal impaction and poop accident. And it's when the patients are coming to our center after 1, 2, 3, 4, 5 years, taking usually polyethylene glycol. In this X-ray, and now you will be expert in radiology today, in this X-ray you can see residual stool after a bowel movement. Okay, it's not so bad, but it's not good. In this one, you can see more residual stool. Wow, it's worst. Wow, this is amazing. This is a lot. And this patient came because he was having accidents. This patient was having accidents every single day at school, at night, every time. He was taking polyethylene glycol. This is one of the most severe cases. You can see poop everywhere, and the patient is under treatment for constipation. And this is a massive fecal impaction. I just want to show you X-rays with a different amount of constipation or fecal impaction. Fecal impaction, again, means obstruction. Something is not leaving the rectum and the sigmoid clean. This cartoon shows you a rectum, so you can see now, right here, the rectum full of poop, the sigmoid, and the left colon, and the patient is straining. When the patient takes osmotic laxatives, this osmotic laxative will produce liquid stool, and then the patient you will see here is going to start to have accidents like this one. And we call this fecal incontinence due to overflow. Once we clean the patient, these patients have bowel control, but they lost the bowel control due to constipation and overflow. In this animation or this movie, I want to show you, imagine this is the rectum, this is the anal canal, this is the anus, this is the poop, the yellowish, and you give osmotic laxative, let's say polyethylene glycol. Now the polyethylene glycol is going to take this brown color and it's going to produce pressure and one accident. You give more polyethylene glycol. Now 2 cups of them. More pressure, one, accident. More Miralax, more polyethylene glycol. Then you will have a real bowel movement, which is the yellow poop. But look what happened when you give more and more and more. The patient is having a bowel movement, but then the parents will be very happy because on the diaper is poop, and then, wow, a lot of polyethylene glycol. And you are not going to be able to differentiate between real poop and polyethylene glycol. So again, fecal control in patients with constipation usually is 100%, so they don't have accidents. But if the constipation start to be worse and worse and worse and worse, and then the colon is super big, the rectum is super big, and you don't have adequate bowel management, the patient is going to have accidents. And sometimes many patients came with the diagnosis of fecal incontinence, but they are not fecal incontinence. They had bowel control. Again, thank you very much. This is my email for Spanish and English. If you have any question, ready to answer.
Thank you, Dr. De La Torre. And we're going to move to the next talk that will be called enemas, indications, how to perform them. That will be given by one of our nurse coordinators, Annie Merritt. Welcome. You're muted.
Thank you for that. I am unmuted now, so let's get going on the enema talk. Okay, so who's an enema for? We've heard a lot about bowel control this morning, and enemas are for people who don't have bowel control. So there can be many reasons for this. There are congenital causes, like we talk about the spectrum of anorectal malformations. Some of the malformations on the more severe end of the spectrum inherently don't have bowel control. Sometimes it's accompanied with a spinal defect like tethered cord or an abnormal sacrum or spina bifida. So for those reasons, the child inherently doesn't have bowel control. Also, we want to mention post-operative changes. So the percentage that we associate different types of anorectal malformation with successful bowel control, we don't guarantee in a reoperation. So when children have multiple operations, we don't know what their bowel control is going to be. Also, in children with Hirschsprung's disease, if there is some damage to the anal canal, then that can result in fecal incontinence as well. Dr. De La Torre talked more about idiopathic constipation and how that presents as a pseudo fecal incontinence when the rectal vault is so full chronically that there will be output that the child can't feel, and that's in a case of idiopathic constipation. And also for age, so before the typical age of toilet training, around 3 years of age, it's expected that those babies and small children don't have bowel control. So that's when we use an enema as a regular regimen if the person needs help with constipation management and they have one of these conditions to limit bowel control. We also use it as a tool for disimpactions or clean outs. So a large volume enema cleanses the colon with a combination of normal saline and liquid glycerin. And the goal is to clean the entire transverse and descending colon to keep the patient clean from stool accidents for 24 hours at a time. And again, it can also be used as a tool for disimpaction. So to clear an accumulation of stool that is blocking the rectum and preventing a chance for otherwise bowel control. So I have a couple of examples to kind of help understand this in a different way. And this first one is an X-ray of a patient who's an 8-year-old female. She has neurogenic bowel, so she had a spinal problem. And she began with our bowel management program. When she first came to us, she was just taking 1 cap of Miralax or polyethylene glycol every other day. So that was the treatment recommended by her primary care physician when she first came to us. And this is what her X-ray looked like. And we can see a large accumulation of stool in the rectum. So we started her on rectal enemas with 300 milliliters of normal saline and 40 milliliters of glycerin. I know it's a very common question of how we come up with these numbers and where do we start. And the truth is that it is a process of trial and error, which is why we have the structure of a week-long bowel management program so that we can titrate exactly what recipe is going to be successful for each kid individually. So it's kind of a guesstimate for a starting place. And one tool that can really help guide that first starting place is that all of our patients have a contrast enema done prior to our bowel management week. We saw some images of that earlier on today. And what that does is shows the total fill volume of the colon. So what's the capacity that the colon can hold? And then we start a little bit lower than that, usually like a third to a half for the total volume of our enema, with, again, the intention of clearing out the rectum, the descending colon, and the transverse. So we started this patient on rectal enemas with 300 of normal saline and 40 of glycerin. And then this was her repeat X-ray when she came back on Monday after doing that regimen over the weekend. So 4 enemas. And now we see a clean X-ray, and she had been clean in her underwear in between the enema times. So our recommendation is to continue on the same daily regimen. We found something that works for her and allows her to be clean outside of this bowel program time. The next example is a 20-month-old male with a history of anorectal malformation. So he is still young. He was on 1 square of X-Lax. We're not necessarily talking about bowel control on the toilet in this instance, but we want to prevent accumulation of stool. We want to prevent constipation from becoming a problem with him. So we had him on 1 square of X-Lax every day, and then he started to go more than 24 hours without a bowel movement. So the mother called and she said, it's been longer and longer in between bowel movements. I think he's starting to get constipated. So we asked for an X-ray, and it revealed this stool ball in the rectum here as well. So they came into clinic, and this is where we used enemas as a tool for disimpaction. We used 100 milliliters of normal saline and 20 milliliters of glycerin. And then this is the X-ray from after the enema. So we can see that the stool ball has cleared. And so we know that the 1 square of X-Lax was not quite enough for him because he was able to accumulate that impaction. So we increased his X-Lax dose to 2 squares daily, and he'll continue on with that regimen, and we'll continue to monitor. So what time do we give an enema? This is a common question from a lot of our families, and it's not what time of day that's specifically important, but it's that it's at the same time every day. So the bowel loves routine, and we want to try and work with that setting and develop that routine as well. So if you choose that the morning is going to be a better time for your family, then every morning is important to do the bowel flush. Or if the evening is better, then that works too, but that evening every single day. And it takes about an hour for the process. So we kind of consider that when we're choosing which time of day is going to be best. The first thing to do is prepare the area. So usually this is done in the bathroom. We'll talk a little bit more about positioning, but most often the child is on the floor so that we can use gravity to help with the enema administration and then transfer over to the toilet. It's really important to have distractions available. This isn't always the most fun procedure. And so accompanying it with things that can be more desirable or, more engaging for the child can make a world of difference. The enema, I'll go into the specific supplies in just a moment, but it does work to gravity. So it's going to be the bag of enema solution needs to be hanging up higher than the child. So having a hook on the wall to hang the bag is really helpful. And then again, for positioning, a yoga mat is a good surface for the child to be laying on so that they're not on the floor of the bathroom, and then it's easy for cleanup. Sometimes pillows and foam wedges for positioning will be more important, and we'll talk about that too. So again, getting all of the supplies together, I'm going to kind of flash some of them in front of the camera. So this is the Foley catheter. It's this long soft tube that we use. And then this is the part that actually goes in through the rectum to deliver the enema. The gravity bag is what we hold the solution in. That looks like this. And then there are connecting pieces to connect the gravity bag to the catheter. Saline solution is the bulk of the enema that we use, and we choose that so that the solution will stay in the colon rather than being absorbed right away. And that just helps the solution be more effective. Prescribed additives are Castile soap or liquid glycerin. Usually we try and use liquid glycerin first, and that's what we call the irritant. So that's the portion of the enema that's going to cause the contraction of the colon and help to break up and expel the stool. We used a syringe that will inflate a balloon on the end of the Foley catheter, and that is what helps keep the catheter in place. And then we use a lubricant for ease of administration and some plastic lined towels or pads to help with cleanup too. Again, just to reiterate about the saline, we use it so that it's just a little bit more effective than it would be if we use regular tap water, so that it can kind of limit the absorption from the colon. And the other reason why we tend to this is that it's really easy to make at home. So it doesn't need to be sterile. It doesn't need to be ordered from the pharmacy. You can just use tap water and with a ratio of 1 liter of water and 1.5 teaspoons of salt. Use warm water so that the salt absorbs more easily, and you just shake it until the salt is dissolved, and then you're ready to go. It is important to make sure that that ratio is exact. If there is not enough salt, then again, the colon will be more likely to absorb the water. And if there's too much salt, then that can be harmful to the kidneys. So we just want to make sure that the ratio is exact, but otherwise it's very easy to make. Glycerin, it can be found on the shelves of pharmacies and of the grocery stores. Sometimes it can be more challenging to find than Castile soap or some other additives, but it is readily available if you order online from Amazon or from Walmart. So these are kind of the brands that we usually guide our patients to, and readily available when you order online. Okay, so again, just to kind of prepare the solution, the first step is that we close off this roller clamp on the gravity bag. So this is what kind of closes the system. So then when we add solution to the bag, it doesn't just run right through. So first clamp off the bag. And I like to have the whole system all put together. So again, connect the bag with, there's this cone shape adapter, which is important to make sure is there. And then that goes into the Foley catheter here, cone to cone. And then we pour in the saline first into the bag, and then we say prime the tubing. So what that means is to roll this clamp up a little bit and watch the saline, the solution, run down through the tubing to the end of the catheter, and then clamp again. And then we add the glycerin to the bag. And the intention of that is so that if you add the saline and the glycerin at the same time, the glycerin is a little bit heavier and it falls to the bottom of the bag first, and it can clog the tubing. So if you coat the tubing with the saline by priming it first and then add the glycerin, it will run more smoothly and protect your supplies so that you can reuse them for longer. So add the saline, prime the tubing, add the glycerin, close up the top, mix the bag. And then we'll put the bag to the side. You can hang it up on the hook, and that's ready to go. And then we want to prepare the balloon for the inside of that's going to hold on the inside of the rectum at the end of the Foley catheter. And kind of our starting place, our rule of thumb is 30 milliliters of water. I'm using air for demonstration, but just water from the sink is what we recommend to use. Sometimes kids will need more than that. Sometimes they can be okay with less than that, but this is a good starting place. And the whole intention is to prevent any leakage from coming back out. So this will create a seal so that the enema solution flows in and stays in so that it can do its job. So this connects to the other port on the catheter. You just kind of stick that on. Now we have our whole system set up. Then we get the child into position. So these are kind of some suggestions of where to start. Anatomically, this is going to help us deliver the enema in the best way. But ultimately, however the child is going to be most comfortable, and if they can receive the fluid and it stays inside, we can work with that. But these are a couple of ways to start. So lying on the left side with the knees up to the chest is one position, or kind of laying on the chest with the bottom up in the air. And then this position can be more helpful when we need gravity to be on our side, if the child has a tendency to be leaking the solution. This is a little video that I hope will play just to kind of give a visual of what it's looking like inside when we deliver the enema. So we'll insert the catheter and then blow up the balloon inside the rectum and then pull back so that it creates that plug, that seal. Then this fluid is delivered so that it fills up the transverse, descending, and rectum. And then we'll dwell with the fluid inside for about 5 to 10 minutes. And then you pull out the catheter, and then here comes the washout. Here comes the bowel movement. And it might come in a couple of different pieces. So this is why we say the process takes about an hour. Kids, even though there might be a large amount of output at first, there might be a little bit more a few minutes later. So we consider the whole hour time to be that same enema. And then this is demonstrating how you'll go the next 23 hours without any output as the stool is moving through the colon until we get to the next day at the enema time when we're ready to go again. Again, we already kind of talked about this, but we'll use lubricant on the end of the catheter, insert the catheter about 4 inches. And then you go over to the syringe and inflate the water so that there's the balloon here. One thing to consider is that if you take your hand off the plunger of this syringe, then the balloon will self-deflate. So you have to inflate the balloon and remove the syringe. And now you can see that there's some space in between my fingers, which is kind of simulating the anal opening and the balloon. So this next step is really important when we pull some tension on the catheter so that it creates the plug so that that seal will be effective. And then we go back over to the roller clamp and deliver the solution. So again, this bag is hanging up on the hook, and we'll roll up the clamp here so that the fluid starts to run down and into the child. Usually we deliver the solution over about 5 to 10 minutes, and that can vary depending on the child's comfort level. And yeah, so you have control over how fast it's running into the child by the roller clamp. So if you can kind of roll it down, it'll run slower, or you can open it all the way up and it will run faster. And again, by using gravity. So if the bag is higher up, it'll run faster, lower, it will run slower. Once everything goes in, then we'll clamp off the tubing again so that there's not backflow up into the tubing. And then this is our dwell time. So we want the solution to sit inside the colon for about 5 to 10 minutes so that it can really do the job of breaking up the stool that's in there, starting with this contraction, and then we're ready to go once we pull out the catheter. I always recommend to transfer the child onto the toilet with everything still in place, because once we pull out the catheter, deflate the balloon and pull out the catheter, the bowel movement might start happening right away. Again, sometimes this dwell time can be a little bit challenging for the child. They might start to feel some fullness and some cramping, which is normal. We're expecting that. We're kind of inducing that. But the longer that it's inside, the better it's going to work. So using a timer can be really helpful with a kiddo, or like having a 10-minute long video or something like that to help them first be distracted and also kind of know where they're at in the process. And then again, we'll transfer over to the toilet with everything in place. And then we bring our syringe back over to this port and put it on here and deflate the balloon. And then the catheter kind of just pulls out through the backside of the toilet, and then the child's already sitting there, and they sit there for about 45 to 60 minutes to have their bowel movement. And so trying to keep them comfortable during this time is really important. You know, it is a long time to be sitting. And so again, with the distractions, having things available that the child is gonna like or enjoy, or, you know, have something to not be thinking about that they're sitting on the toilet for so long, and having a stool or pillows for positioning and comfort can be really helpful too. So how can we make this experience just kind of a normal part of their day rather than a medical procedure that is undesirable? And so just a couple tips, you know, it could feel like information overload. I think when we first start to propose this to families, there's a lot of medical pieces, there's a lot of instructions, but we'll just try to relax and know that it will get easier. For every reason, the first couple of enemas are going to be the hardest. If you can get all the supplies prepared and together and kind of run through them beforehand, the more that the caregiver is comfortable with it, then the more the child's going to be comfortable with it too. So familiarizing yourself with the supplies and the process can be really helpful. Of course, two sets of hands are going to be easier than doing it alone. I know that's not always available, but if you can get help, then please ask for it. And just for the comfort of the child, to making sure that they're going into this process really hydrated can be helpful. So make sure that they drink plenty of fluids during the day, and they'll be more comfortable during the process too. We'll go through a couple of scenarios of some common problems that can arise and solutions for them. One is that the enema fluid is leaking out before it all goes in. So we're using the balloon as a seal, but it's not quite effective, and the enema solution is still leaking out. You can make a larger balloon, so you can increase the balloon size by 10 milliliters of water. And see if that helps. The other thing is just to pull tension. Like we said, we have to pull back the tension. Some kids need this tension to be held throughout the whole process. Some of them don't, but if you see leaking, the first step will be just to kind of pull in the tube, and that might resolve it. If it doesn't, or if the balloon pops out, then we'll need a bigger balloon, and you can increase by 10 milliliters of water. If the child's having cramping or discomfort, we can slow down the solution and see if that helps. Sometimes running it a little bit too quickly can be a shock to the system. And so that's one intervention, is to run it more slowly. Another thing is to make the solution a little bit warmer. So the way I recommend to do that is to, after everything is all ready, you can take a big bowl of hot water from the tap. So not boiling, just hot water from the sink, and make sure that the top is closed and everything is sealed, but you can just put the enema solution into that bowl of warm water and kind of give it a warm bath, and then it will be warmer when you're administering it, and that can ease some of the cramping and discomfort as well. Something else that can happen is the enema solution flows in okay, and then you move the child to the toilet, and then you pull out the catheter and nothing comes out, or very little comes out. The most common reason for this is because the colon absorbed the water, even though we're using saline and we have an additive. If the child's a little bit dehydrated, that can still happen. That's the most common reason. So we'll just monitor for other symptoms. If they have a really big distended belly, they're very uncomfortable, or they're vomiting, then that's a reason to give a call to your provider. But most commonly, it's just because the child absorbed the solution. So make note of it and go on with your day. And then another thing that can happen is the child can't hold the fluid in for the dwell time, or even tolerate the full solution going in, because they're feeling full and they're feeling cramping and they're feeling like they have to go to the bathroom right then. So you just try the best you can. Even a couple of minutes is better than nothing, and you can work up to it. Again, the first couple enemas are always going to be kind of the hardest, and the more that everybody gets used to it, the easier the pathway to our goals will be. And so that is the spiel, and I'm happy to answer any questions that you may have.
Thank you so much, Annie. There are some questions in the chat, and I would appreciate if you can go ahead and start answering them while I invite our next speaker, our other nurse coordinator, Amy Krause. So welcome, Amy. And she's going to talk about rectal irrigations, how to perform them.
Okay, I'm just scrolling through the chat now. One of the questions is, what is the dose of liquid glycerin? Is it according to patient's weight? And the answer is no. Again, this is part of the trial and error process. So we'll start with a number depending on kind of how severe we determine the constipation to be on X-ray and on contrast enema, and go from there. If they're not effectively cleaning out, then we move up on the glycerin. So typically start fairly low between, I would say, 10 to 20 milliliters of glycerin. But again, that depends on the severity of the constipation, not necessarily the patient's weight. Is the bowel management painful? I heard many desperate stories. What if my child has diarrhea because of a virus? Will he have accidents? So we say that no, it's not painful. It should not be painful. And if it is, and that's something that we need to discuss. It is a new experience and it might not be the most comfortable thing. Sometimes having cramps and having a bowel movement can inherently be painful, and we are inducing that. So we'll work together, but no, inserting the catheter and inserting the fluid should not be painful. If your child has diarrhea because of a virus, unfortunately, we have to just kind of let the virus run its course. So you can try to continue with the daily enema regimen if that's what you're on, and see if that can kind of reduce the number of bowel movements, of loose stools throughout the day. Usually it doesn't. So in most cases, our patients will kind of hold their regimen while the child is suffering from the GI virus, and then resume the treatment once the virus is done. And yes, they may have accidents during that time. It's just an illness that we would have to work through. What does having mucus stools after enemas signify? So the bowel is always creating mucus, and usually it's kind of disguised in the stool, so we don't see it as much. But when we're on a bowel program that's expelling the stool every day, or in a comprehensive way, the way that it is with enemas, we'll see the mucus present more, but it is not concerning. So we just reassure our patients that that's not concerning. It's a normal finding. Is there a milliliter per kilogram starting point for the saline volume? Again, no, this is the trial and error. A kind of loose starting place, if we're getting a contrast enema before we start the enema regimen, is about a third or a half of the total fill volume of the colon. That's where we start. So most often that's usually between 200 and maybe 500 milliliters of normal saline, but you pick a starting point and then make adjustments based on how effective it was. Would it be necessary? Yes.
I'm just going to ask you to type your answers so we can move on with Amy.
Okay.
Yes.
Sure. Of
so we're not
course.
so delayed. Thank you so much. That was a great talk. So Amy Krause is our other nurse coordinator, and she's going to talk to us about rectal irrigations. Welcome, Amy.
Thanks, Dr. Bishop. Oh, sorry, Annie and I are in the same room. All right, so I'm going to go over rectal irrigations. And like Dr. Bishop said, I am Amy Krause. I'm one of the nurses with this program. And I have no disclosures. So really the objectives of this talk is developing understanding and why we do rectal irrigations, and going through and understanding step by step the process of doing the rectal irrigations. And really, I'm going to go through a case study and just show some x-rays and just see the clinical exam findings. I think the x-rays can be really helpful in understanding it a little bit better. So what are the main reasons that we do the rectal irrigations? It is really a life-saving procedure that decompresses the colon. It cleans the colon out of stool, especially with Hirschsprung's gas that collects in the stool. So when is it needed? Typically, this is needed for Hirschsprung's disease prior to any sort of pull-through surgery that we're doing. And then anytime a child has enterocolitis, we need them to be on an irrigation protocol. And that protocol typically is about 3 months. We start the first month, 3 irrigations a day. The second month, if the x-rays look good, then we go to 2 irrigations a day. And then the last month is 1 irrigation a day. So a case study, this is a real life scenario that happened. We had a 1-month-old baby that was admitted from an outside hospital. They had severe abdominal distension. They were not feeding very well. They had no stool for 24 hours, history of trisomy 21. Their weight, they were pretty little, 3.4 kilograms. A contrast enema was done on day of life 7 at this outside hospital, and it did show that there was a meconium plug, which ended up passing. They thought it was benign. They sent the baby home just with PRN suppositories, and they chalked it up to being constipation. At 2 months of age, the baby came back to the pediatrician, the local pediatrician, still not very good weight gain. Abdominal wall was still very distended, constipated. The pediatrician referred them to us, Children's Hospital Colorado. Before they even came to see us, they were life flighted from their local emergency room to Children's. When they got here, they had extreme abdominal distension. Their heart rate was way up. They were very tachycardic, didn't have very good perfusion through their extremities, and had very low urine output. So immediately what we did was we got an abdominal x-ray, and this is a very classic and great x-ray. So you see that the distending colon is full of gas and very dilated. This x-ray here is very concerning for Hirschsprung's disease. So what we did next is we admitted the child. We made sure that we got a PICC line in, a good access. We wanted to make sure that we got this child fluids. An antibiotic that's started with kids that have Hirschsprung's is Flagyl. It works specifically on the colon. And then the most important thing that we could do for this child is rectal irrigations. Those rectal irrigations, they completely decompress the colon and they are life-saving. Next, after we got them completely decompressed, we did a contrast enema. This shows us any parts of the colon that are dilated or parts that are more narrow, which is very important for Hirschsprung's disease. And then we did a rectal suction biopsy just to see if parts of the colon, what parts had Hirschsprung's or not. All right, I'm going to try doing this video. Hopefully it will work. Let me see. And this video is just kind of going through the step-by-steps. We use kidney basins, 2 syringes. We want to use generous amounts of lubricant. A Foley catheter, if your child is below 1 year old, we'll do a 16 French. If they're above 1, then we typically do 24 French. You want to make sure that the saline is warm. And then we're going to insert the Foley catheter into the rectum and decompress the stool and gas out of the colon. And with Hirschsprung's, or if your child has enterocolitis, you have to kind of get the stool out in sections. It's not moving through the part of the colon that is not working very well. And we usually say putting about 10 to 20 mils at a time and decompressing the colon. And as you see, the stool is coming out, the colon's getting smaller, and you want to continue the irrigations until it basically is clear coming out. And then you're gonna wash everything with soap and water. These supplies can be reused. So as we discussed, and this is a good, you can take a picture of this if you'd like. We have the 16 French Foley catheter for any kids under age 1, 24 French Foley catheter for ages over 1 years of old. We have our water soluble lubricant that you want to use generous amounts of that. 60 ml syringes. I usually have 2 just ready, and I'll have someone else filling it up just because you want to kind of go quickly and get as much out as you can. And then typically, like in the video, we showed the child was in their supine position. If they're a little older, lying on their left side can work too. And you're going to insert the Foley catheter and make sure one side is in the Foley, the kidney basin. And then something to know is that you can insert the Foley all the way to the Y end. We just want to make sure that we don't hit any resistance. If you hit resistance, that's when you just add water. You're going to flush the colon, unconnect it, and let it flow back in. And using the large syringe, you're going to inject 5, we usually do like 10 to 20 of the normal saline into the catheter at a time. And then as you're going, you're going to slowly pull back. You're going to get stool gas that kind of flows back. And you're just going to keep repeating this process until basically you get all the gas pockets, all the stool out of the colon, and that it's running clear. And then here is a really great picture. This was the one that we did before the irrigation that you see on the left side. And then this is after the irrigation. And you see that the colon is completely decompressed. The child's abdomen is no longer distended. And that is just a great picture of what the rectal irrigations can do and how effective they are. And that is all. Does anyone have any questions?
There's one question that I think it's a great one. How should
Dr.
you
Rush, I think you're on mute.
Can you hear me? I'm not mute. Can you hear me? So the question is how to decide. I'm going to answer because I think Amy cannot hear me. So the question is how to decide if you should do rectal irrigation or rectal enema. So again, rectal irrigation is to decompress the colon. It's for patients that have enterocolitis for Hirschsprung. So we are draining liquid stool and gas. Enema is a completely different concept. We are infusing a large volume and we expect the patient to expel itself. So do not confuse rectal irrigation, where we are passing a large catheter and decompressing the colon, with enema, that it's infusing a large volume to either disimpact a patient or treat fecal incontinence. So we're going to take a quick break of 7 minutes and then we will be back. So this is a quick bathroom break and we'll be back in 7 minutes. See you soon. Okay, so it's time to restart, and now we're gonna talk how to treat fecal incontinence, and there has been a lot of questions in the chat, so hopefully we'll answer them with this talk. So again, the first task for the physician, if a patient comes to clinic complaining of fecal incontinence, you have to determine, is this true fecal incontinence, no bowel control, or this is a case of constipation with bowel control and overflow pseudo-incontinence. So the patients that suffer from fecal incontinence, as we discussed, are patients with anorectal malformation with poor prognosis for bowel control, rectal bladder neck fistula, cloaca with a common channel more than 3 centimeters, patients that have a sacral ratio of less than 0.4, patients with tetrachord myelomeningocele, patients with Hirschsprung, with damaged anal canal, patients with absent sacrum, myelomeningocele, and large sacrococcygeal teratoma. The task number 2 is to determine if the patient suffers from fecal incontinence and hypomotility, the colon that moves slow, or fecal incontinence and hypermotility, the colon that moves very fast, tendency to diarrhea. And the contrast enema helps us with this differentiation. Here you can see a contrast enema where we see a dilated colon. This is a patient that the colon tends to move very slowly. This is actually an easier patient to treat because this patient will need a large and concentrated enema to clean the colon, but in between enemas, this is a colon that by itself, it tends to stay quiet. So if you clean the colon properly, the patient will have no stool accidents. On the other hand, this is a patient with a non-dilated colon. So in the contrast enema, just by looking, we suspect this is a colon that has a tendency to be constantly moving. As you can imagine, cleaning this colon, it's easier. The challenge portion here is how do we keep this colon quiet in between enemas, since this is a colon that tends to constantly move. So those are the patients that will need, besides the enema, medication to slow down the colon. So again, this patient will need a small enema, but will need constipating diet, 3 meals per day, and Imodium loperamide to slow down the colon. What is the recipe of the enema? So again, we don't go by height, by weight, by milliliters, by kilo. So this is the range of what we use. The base of our enema is saline solution. So we range from 150 mLs to 1,000 mLs. And the irritants that we will use to concentrate the enema to irritate the colon and make the bowel contract are in this order. We start with liquid glycerin from 10 to 90 mLs. Then the next one is Castile soap. This is a very mild hand soap based of glycerin too. We use between 10 and 80 mLs. And as our last resource, I would say we use less and less is the Fleet phosphate enema. If we have to use phosphate enema, I only use according to the age because of the risk of hyperphosphatemia and electrolyte disturbance. So if you look especially in young kids, there is the risk of death from inappropriate use of fleet enema. So between 2 and 4 years of age, I only use half of a pediatric fleet. That's 33 mLs. Between 4 and 10 years of age, I use a pediatric fleet, 66 mLs. And over 10 years of age, we use an adult fleet that is 133 mLs. Now, based on the contrast enema, the characteristics of the colon, you're gonna pick up a recipe to start. And always people ask me, give me one recipe. So I'm giving you our most popular recipes: 400 mLs of saline and 20 mLs of glycerin, 300 mLs of saline and 15 mLs of glycerin, 500 mLs of saline and 40 mLs of glycerin. This is just if you need something to start working with. But the reality is, it doesn't matter with what recipe you start. It matters that you follow the patient, you look at the x-ray, and you make modifications according to it. So again, key for success, look at the abdominal radiograph done immediately after the enema and the sitting in the toilet time. You want to make sure that the enema has completely cleaned the rectum and the left colon. If in the abdominal x-ray you see a lot of stool in the rectum and left colon, your enema did not do its purpose. You have to change it. You have to increase the concentration. And then you're going to listen to parents and patients about number and characteristics and time of stool accidents, and change the enema based on the x-ray and based on the report. So here is an example. We are seeing an x-ray, and this is done after the enema. The rectum is clean, but you're seeing this granulation. This is all stool. So, and again, when we do an enema, we want to have a rectum and left colon clean, because we believe it takes 24 hours in the majority of people for the stool in the right colon to reach the rectum. So that's why we want this area here to be clean. So let's suppose this patient was on 300 of saline and 15 of glycerin. Today I'm going to go to 325 of glycerin. And then I'm going to see the x-ray. And you're going to compare this x-ray with this x-ray. And if you compare them, now you can see that the rectum and the left colon are clean.
But Dr.
So,
Bischoff, excuse me,
yes,
we're not seeing your slides. Are you sharing slides?
I am.
We're not seeing those.
Okay,
I
so
thought you were
let's...
talking
I can see
extemporaneously.
the slides, Ray.
You can?
Yes.
Okay.
Yeah, I could see them.
All right. Never mind.
Okay, are you seeing now?
So right
Now I
now
can.
she's
Now I can see them,
sending
yeah.
2 x-rays.
Yep, we see them
Perfect.
now.
Okay, so again, this is an x-ray that we have the clean rectum, but the left colon has a lot of stool. So we need to increase the concentration of the enemas. And now we can see clean rectum and clean left colon. So it means whatever you made, it was correct, because that's the goal of the enema. Now, here is an example of why it's so important to have a contrast enema. The contrast enema will help you guide where you need to look when you're trying to interpret the results of your enema. This case is a patient that was operated for Hirschsprung, and all the colon that the patient has is here on the opposite side of where we normally would be looking. We normally would be looking on the left side of the patient, that it's the right side of the screen. In this case, the patient has a short amount of colon, and all the colon is in the left side of the screen, the right side of the patient. So this is the importance of why we need the contrast enema. Otherwise, you cannot determine the result of your image. So again, the same patient, remember, we are looking here. So imagine you did an enema for this patient. Let's suppose we did 150 mLs of saline and 20 of glycerin, and we are seeing a lot of stool in the rectum. So we have to increase the concentration. So we're going to go to 150 of saline and 30 of glycerin, and now we can see that this was the right decision because the x-ray is clean. So that's the key for bowel management, is comparing one x-ray with the other, knowing that you need a clean left colon and rectum. In this case, it's all in the opposite side. This is another example of why it is important to have a contrast enema. In this case, the cecum overlaps with the rectum. And remember, we always expect to have stool in the right colon, but we need the rectum and left colon to be clean. So this is a 3 years old with anorectal malformation and fecal incontinence. The radiologist used 550 mLs to fill the entire colon. Usually we say you need about a third of the volume that they use to fill the entire colon, because our main goal is to clean rectum and left colon, and that's a third of the entire colon. The abdominal radiograph after 24 hours shows residual contrast material. That means that we are dealing with a colon that moves slow. So for this patient, we started him on 200 mLs of normal saline and 20 of glycerin. And on the next day, you don't see any contrast material and the x-ray is clean. Now, this is a 3 years old anorectal malformation that has been unable to toilet train. So if you look at the contrast enema, you see that there is a dilated rectum and lots of hard stool. So this patient is showing signs of constipation. It's a slow motility colon. So this is the abdominal x-ray on the first day of bowel management. And we started him on 200 mLs of normal saline and 30 mLs of glycerin. So now we're going to look and see if the rectum and the left colon are clean after our enema. And this is the image, and you can see that we succeeded. The rectum and the left colon are clean. We see stool in the right colon, which doesn't matter because it will take 24 hours for this stool to come down, and that's the time the patient will be receiving another enema. This was a patient that had borderline bowel control. Again, for patients that have borderline bowel control, we prefer to start them on enemas, and then every year during a vacation, we'll invite them for a laxative trial to see if they can achieve voluntary bowel movements with laxatives. It's important to understand that enema is a very passive action. We put the solution in, we have a bowel movement at a controlled time immediately after the enema. Doesn't require much effort from the child other than accepting the enema. The patient will be clean. When we're talking about laxatives, it's a different ballgame. We need the participation of the child. The child has to be alert to when he or she feels the need to go to the bathroom. So maturity is also important for laxative trials. Now, if you have a complete clean x-ray, in this case, you can see that the entire colon is clean. And the parents are reporting stool accidents throughout the day. That's when you have the authorization to start the patient on Imodium. Your enema is cleaning the colon, but the patient is having real stool accidents. That means you're dealing with a colon that moves fast. So you should start the patient on Imodium. Once we have determined that the treatment for this child is enemas for life, because they were born with a poor prognosis for bowel control, the anal canal has been damaged, they are borderline bowel control, they have failed multiple laxative trials, and the child wants to become independent. That's when we can offer a Malone procedure. That's when we connect the appendix to the belly button. So instead of receiving the enemas from the rectum, the child can sit in the toilet, pass a little tube through the belly button, and give the enema in an antegrade fashion from here to there. Now, important to understand, Malone procedure or antegrade enema procedures are not the treatment for fecal incontinence. The treatment for fecal incontinence is finding the right recipe that keeps the patient clean. This is just a different way to deliver the solution. And against what most people believe, this is not more efficient than giving rectal enemas. The reason is when we give the rectal enemas, as you saw in the lecture, we use a balloon. And there is a holding time. The solution stays in contact with that stool. Once we give enemas from above, we lose that holding time. The solution just passes faster. So it's not more efficient. It's just a different way to give the enema. So this is a child that has the Malone procedure, and this is an 8 French, a tiny tube that we pass, and the child can give the enema himself or herself. I'm happy to answer questions about the treatment of fecal incontinence, but I hope you understood the idea that it doesn't matter the recipe that you start, but knowing how to look at the x-ray and making sure that the enema is doing its job, that it's to clean the rectum and left colon, that's the key for a successful bowel management. So I'm going to stop sharing. Oops. Sorry, I lost my Zoom here. Okay. What is an appropriate age for the Malone procedure? Whenever the child wants. So usually we say the child should ask for us, or when the child is too heavy, the parents start having back pain, that's another option. And if the child has urological conditions, we want to determine together when it's time for a Mitrofanov and a Malone, so we do it together. There's a question about SITS mark studies. We don't do it. With the contrast enema, we obtained all the information that we need. Okay, so I'm gonna invite Dr. De La Torre again. He will now talk to us about how to treat constipation.
Okay, hello again. Now, I want to explain you how we treat constipation. We can spend hours talking about constipation because it's the most common problem in the world. But just we have 20 minutes. So I'm going to explain you slowly and step by step. I hope we can cover everything. And at the end of this meeting, you can have the opportunity to participate during the Q&A session. So let's say this is the patient with constipation. You already know that this patient has severe, significant, important constipation. Why? Because the rectum is very dilated, including the sigma. He has fecal impaction. This is not happening just in 24 hours. So this patient is chronically ill. He has long-standing constipation. So the step number one, when we saw a new patient or a patient with constipation, we need to do the contrast enema that I already explained in the previous conference, but always you need to take an x-ray. If you want to start a bowel management and treat patients with constipation, and you don't have an initial x-ray, you start in a wrong decision. This is another patient with constipation. And again, I am not going to do the same treatment for this patient because the rectum is almost normal in size. Okay, how we treat constipation. Step number one. Again, step number one. If you want to treat a patient with constipation or your daughter, your son, or you suffer constipation, you must have an abdominal x-ray. The abdominal x-ray is going to show the amount of stool that the patient has in the rectum and the sigmoid and the left colon. We are not worried about the right colon. Remember that. Sometimes even just with the x-ray, we already know the size of the rectum because the stool function or works like a contrast in some patients. So step number one, take the x-ray. And the question in the x-ray is how much stool is in the rectum and the sigmoid. The stool is hard. Yes, you can see the difference between this stool versus this one, which is soft, almost liquid. This one is different. These are stool balls, hard stool balls. So number one, take an x-ray. If the x-ray shows significant amount of stool, then you need to go to the step number two. The step number two, always in a patient with fecal impaction, and again, fecal impaction means the chronic accumulation of poop in the rectum and sigmoid. Fecal impaction could be mild, moderate, severe. Fecal impaction could be partial obstruction or complete obstruction. So in order to do a bowel management in patients with constipation and be successful, the step number two after the x-ray is to do a clean out of this segment of the large bowel. Enema, you already know what is an enema, how to give an enema. Is my preference to clean out. There are many other ways to do a clean out. One of them is to introduce an nasogastric tube, which is NG, and then give liters and liters and liters of polyethylene glycol with electrolytes. In the market, the most common name is Go Lightly. We don't like to do that because patients with fecal impaction during the program, they can have another fecal impaction. If you have already a fecal impaction, the risk to have another fecal impaction is really high. So you are not going to do NG and Go Lightly at home. But what you can do at home is the enema. Sometimes we just give one enema. Sometimes we prescribe enemas for a week. Sometimes we need to maintain the patient on enemas for months. Sometimes the enema is not going to clean out the rectum. When the fecal impaction is massive, is very important, is significant, is almost a complete obstruction, an enema is a high risk because you give the enema and the patient has obstruction with the stool balls, and the enema is going to be retained in the colon, and the patient can have severe complications. So in those patients that do not respond to an enema or they have severe fecal impaction, the next step is to admit the patient in the hospital, take the patient to the OR, and under general anesthesia and a load of fluids, IV fluids, and antibiotics, IV antibiotics, we do a manual fecal disinfection. So these are the three main procedures to complete the step number two. How we know if we are doing a complete clean out? The only way is with an x-ray. There is no other way. Sometimes we remove a lot of stool in the OR. Sometimes we do 3, 4, 5 enemas, and the parents say, wow, he pooped like crazy. He had a huge amount of stool. And the x-ray still has fecal impaction or significant residual stool. Okay. Step number 3. Confirm that the rectum and the sigmoid they are clean. So remember, this patient is the same. Look, he has a stapler here, and it's the same patient. So this patient requires 3 weeks with enemas. 3 weeks with enemas. Once we obtain this x-ray, perfect. The patient now is clean, and then you can proceed with the next step. The next step is we have 2 options. In patients with chronic months or years with accidents, and they use diapers, pull-ups, or any other protection because they have accidents, and they are not full toilet trained, or they are 5 years, 6 years, but they have been using this protection because they have accident. My recommendation is to keep the enemas for a long time. Long time is at least 3 months. And then you can move for a laxative. Some patients are not going to respond to laxatives, and they will need enemas forever and ever. So the next step is the enema in some patients. For a long time, remember, we use sometimes the enema for a week, a month, 6 months, and then we move for the next step, which is the step number 5. The step number 5, pay attention, this is very important, is the laxative, the use of laxative. The most common error in the treatment of constipation is the parents go to the GI, goes to the pediatrician, go with the doctor, and they say, okay, my child is not pooping, my child is having issues, etc., etc. And the step number 1 is this, the number 5. They just prescribe laxatives. And the laxative should be the step number 5. What or is the ideal laxative? Because this is a very common question from all the parents, doctors, patients. What is the best laxatives? And I said, okay, the best laxative is the laxative that is going to stimulate the rectum and the sigmoid. We don't want to stimulate other segments of the intestinal tract. The ideal laxative should produce only one bowel movement. The ideal laxative is going to allow the patient to predict the time to poop. You take the laxative at 8 a.m. and then you are going to poop at 8 p.m. So 12 hours. You can predict the time. The ideal laxative makes a complete clean out of the rectum, sigmoid, and lymph colon. The ideal laxative is not going to produce pain. The ideal laxative is not going to produce colicky pain. We can determine the amount of laxative based on the weight of the patient. If the patient is 3 kilos, 10 kilos, 20 kilos, he's going to take 20 tablets, 3 tablets, whatever. This laxative guarantee no more accumulation of stool. In other words, no more fecal impaction. The laxative exists in tablets, liquid, drops, chocolate squares, etc., etc. All presentation. It tastes very nice, very good, and no side effects. In the world, we don't have yet the ideal laxative, but there is only one that is very close to this one. Very, very close. We have 4 types of laxatives. Fiber, which is this one. Softeners, osmotics, and stimulant laxatives. And the stimulant laxative, we have two different types. One is based on Senna, and the other one is based on Visacodol. Senna is a pro-medication. So you take the Senna and it's inactive. When the Senna is in the colon, it's going to be active. So this is very good because this medication is just going to work on the large bowel, just in the colon. The Visacodol is going to stimulate also the small bowel. You swallow the pill with Visacodol, and you are going to have motility in the small bowel, and you can feel the colicky pain in the small bowel, and you don't know if you need to poop or not because you feel motility. You feel colicky pain. But with Senna, the colicky pain is just from the large bowel. The osmotic, we already explained, that produce more problems in the group of patients with significant constipation. I will show you a video making the difference between the osmotic and the stimulant.
Laxatives are commonly used to increase bowel movements and treat constipation. Two common types are Senna and PEG. Senna is a stimulant laxative derived from the Senna plant. It works differently from other stimulant laxatives by remaining inactive while traveling through the stomach and small intestine. It is only activated once inside the colon by the normal colonic bacteria. Then, active Senna stimulates the mucosa and nerve plexuses, generating motility of the colon and triggering the urge to have a bowel movement. The time it takes to start is usually 8 hours after ingesting. This helps parents predict the next poop. Polyethylene glycol, also known as PEG, is an osmotic laxative. It works by drawing water from the rest of the body into the colon. The poop created from taking PEG is not like real poop. It's more like fake poop, made of a mixture of water and PEG with very little real poop. As a result, PEG creates very soft or watery poops that make accidents more common. How pooping works and the anatomy involved. When working correctly, the rectum and sigmoid colon are the natural reservoirs for poop inside the colon. They fill with poop throughout the day, and once full to their maximum capacity, they stretch, and we feel the urge to have a bowel movement. When finished, the rectum and sigmoid colon are clean and empty. Constipation occurs when a child does not have regular bowel movements. If not emptied regularly, poop remaining in the rectum for more than 24 hours can become hard, dry, large balls. These poop balls create obstructions or fecal impaction, making the next bowel movement difficult and painful. For children with chronic constipation, an abdominal X-ray must be performed to see how much poop has accumulated in the rectum and determine the degree of fecal impaction. If fecal impaction is not detected, then laxatives can be prescribed. However, most children with constipation will have some degree of fecal impaction. Therefore, the first step is to clean out the colon with an enema. What is the effect of using laxatives in patients with fecal impaction who did not do a cleanout? If Senna is taken without a cleanout, the patient will feel painful cramps as the colon contracts and tries to clear the fecal impaction. If PEG is taken without a cleanout, the fake watery poop slips around the hard poop, making bowel movements challenging to control and resulting in fecal accidents. In addition, PEG can make a fecal obstruction bigger, which leads to more fecal accidents. What is the effect of using laxatives in patients without fecal impaction or who received a cleanout? When Senna is taken after a cleanout, the colon is stimulated, and after about 8 hours, there is an urge to have a bowel movement. For patients with chronic constipation who have an enlarged rectum, the motility of the colon is reduced. The use of Senna improves motility and decreases the possibility to accumulate poop in the rectum and sigmoid. When PEG is taken after a cleanout, it produces fake watery bowel movements that are difficult to hold, resulting in accidents. In addition, the poop is more likely to accumulate, leading to more fecal accidents. For patients with an enlarged rectum, polyethylene glycol and other osmotic laxatives do not improve the motility of the colon, leaving it stretched out and more likely to accumulate poop. The Colorectal Center at Children's Hospital Colorado offers a monthly bowel management program where we treat children with severe constipation. To find out more, please visit the website below.
So you already look how is the difference between the stimulant and the osmotic. So the next step is how much laxative we need to do. We need to prescribe, the patient needs. This is based on trial and error. So you need experience, you need to have the x-ray, you need to have the contrast enema, and then you will see, oh, this patient is not going to respond to 15 milligrams because the rectum is so big and he needed 6 months with enema. So you need to start with a big amount of laxative. So let me explain you how can we do that. Let's say in this hypothetical scenario, I said, okay, based on the history of the patient, the contrast enema and everything, this patient needs 4. So the magic number is 4. 4 tablets of 8.6 milligrams, 4 squares of 15 milligrams, 4 whatever, 4 milliliters of senna. Let's say the magic number is 4. So I get 4, and then after 8 hours, look, beautiful poop, a big bowel movement. This is the time for the x-ray. The patient has a bowel movement, x-ray, and the x-ray is clean, rectum, sigmoid, left colon. That means is adequate. This patient is going to need 4 tablets, 4 squares, 4 milliliters. It doesn't matter what is that. 4 is the magic number. Let me show you scenario number 2. Is the similar patient, same gender, same age, same contrast enema, same time with enemas. Because in the other patient 4 was perfect, I said, I'm going to repeat the same amount of senna. 4. And look what happened. I get 4, and again, 8 hours after, oof, poop. Mom called you and say, wow, my daughter has the biggest poop in her life. Beautiful, great, we are very happy. Move, x-ray right after. Look, residual stool in the rectum and left colon. So that means 4 is not the magic number for this patient. This patient is going to need most probably more than 4, probably 5, 4.5, 5.5, 6, I don't know. The number is going to be higher than 4. Let's move to the scenario number 3. This is another patient, the same gender, weight, same time with constipation, is the same. And 4 is the magic number. So I'm going to get 4. I get 4, and look what happened. 8 hours after, 1, 2, 3, 4 poops. And then just 1, 2, 3 mucosae. And then even after, more mucosae. Ugh, this 4 was too much. This is excessive. We don't need an x-ray in this patient. What we need to do is, okay, we need to repeat senna, but with less than 4, probably 3, 3.5. And this is the 4th scenario. This is another patient with the same clinical picture. The magic number 4, in 24 hours, no bowel movement. Wow, we don't need an x-ray. We don't need an x-ray. This patient needs more than 4. So in summary is, you can start with any number here. And then you need to assess if the response was excessive, adequate, insufficient, or no response. If it's adequate, the patient has a good bowel movement and the x-ray is clean. You continue with 4. If it's excessive, okay, you need to go down, probably 3.5, 3, 2, I don't know. But again, reassess. If it's insufficient or no response, the patient needs more than 4. Every time you need to increase the amount of laxative, you need to clean out with an enema. So enema and 5 in this scenario. This is how we work day by day, and usually in 4, 5, 6 days, we find the amount of laxative that the patient needs. It's not just to give 3 tablets and I will see you in 1 month or in 3 months. No, that doesn't work in bowel management. Again, thank you very much. If you have any question, I'm happy to answer.
Thank you, Dr. De La Torre. There are many questions. One, can you tell more about diet for constipated patients? Oops, Dr.
Okay.
De La, yeah.
So diet, when you say diet, you can buy a book in the library or in Amazon, and there are many books talking about laxative diet. You can use whatever you want. The diet is, I don't want to say it's not important, but it's not the most important. It's most, in patients with constipation, the most important is discipline with the meals. What we recommend is to give 1 meal in the morning, like a good breakfast, then another good meal around noon, like a lunch, and then in the afternoon or in the evening, a good meal like a dinner. And please try to avoid food in between. In English, we said snacks. En español decimos botanas, entre comidas. So try to avoid these snacks. Just 3 meals and no snacks.
Thank you very much, Dr. De La Torre. We are now going to invite our next speaker, Betsy Dunbar, who is a physician assistant with us here at the International Center for Colorectal and Urogenital Care. And she also dedicates a lot of her time managing patients with spina bifida. I think our colorectal center is the first one who has formally joined a multidisciplinary spina bifida and a spinal defect clinic. And we are extremely proud to collaborate with this multidisciplinary group. So welcome, Betsy.
Thank you so much for the introduction, and thank you for inviting us to participate. We're glad that you're here joining us for this program. As Dr. Bischoff said, today this presentation will be about goals or bowel management in our spina bifida population. Much of the information we'll present here will mirror some of the information that you've heard in other places.
Betsy, we cannot see you. I don't know if you have a camera or not.
I do. Let's, there we go. Maybe?
No, I don't know why. Huh. It's okay. You can just continue. Sorry.
Okay, maybe that worked that time. So when we think of our patients with spina bifida, we divide them into age groups similar to the information that's presented earlier throughout the lecture today. So looking at the goals based on age for our patients in the 0 to 3 age group, and we'll use 3 as an age for social continence, knowing that that might look different for every patient. Our goal is to prevent constipation, and in some of our patients, we do need to use medications like laxatives, either oral or rectal, or enemas, protect skin from a diaper rash, and then also establish the relationship with our care team. We think that's one of the most important things in the first years of life. We see you at our center beginning at around 3 months of age and see you every 3 months to a year, and then 6 months thereafter until you're 6, and then annually from there. starting at age 3, as reflected in other areas of this program, social continence becomes more important. So our goal is to help you achieve social continence and then stay clean and dry in underwear if that's the goal for your child. And then as your child ages, we adapt their bowel regimen to fit their needs and changes in what is happening. We also think it's very important for your child to become independent in a way that is both age appropriate and developmentally appropriate. And we continue to have those conversations throughout our appointments. There we go. You might have heard us in Spina Bifida Clinic or on Spina Bifida resources talk about neurogenic bowel, or sometimes that's referred to as neurogenic bowel dysfunction. That basically means that there's damage to the nerves that control bowel function, which can cause fecal incontinence or constipation. In about 80% of patients with Spina Bifida, that presents as fecal incontinence, which means they have no bowel control and they'll need enemas to manage their bowel program. For the remaining 20%, that would present as constipation. So they would have decreased bowel function, constipation, and therefore need laxatives. Our center has done quite a bit of research on our spina bifida population. In one recent study, we looked at spina bifida and bowel control. Patients with who are less likely to have bowel control are patients who have a wheelchair, have a VP shunt for hydrocephalus, have urinary incontinence, or have L3 or L4 lesions. Therefore, patients who are more likely to have bowel control are patients who don't need a wheelchair, do not have a VP shunt, have urinary continence, and have higher lesions at the L1, L2 level or higher. And I think one of the most important questions people ask is there a relationship between fecal continence and prenatal repair? And so far, our research has not found that relationship, but we'll continue to look at that. You might be wondering, as we've been going through this presentation, what makes spina bifida different from the other groups that we've talked about in this program, such as anorectal malformations and chronic idiopathic constipation. One of the main differences is the fact that patients with spina bifida, or a majority of them, do not have control of their sphincter, which is the muscle group that controls if stool comes in or comes out. This can also make enemas more difficult to administer and can lead to accidents if not managed appropriately. As I just mentioned, enemas can be more difficult in this group of patients. So things that we can do to troubleshoot that, cone enemas can be a great solution, as the cone, which you can probably see at the end right here, can serve as a plug and it won't fall out of the rectum, and it also can hold the solution in, providing a better seal. We also have you inflate the balloon more than you might in other populations. So we feel comfortable in inflating up to 50 to 60 mLs. And this is something that we'll talk about in other lectures as well. But I think we also recommend changing the delivery system. So trying something like transanal irrigation or antegrade continence enemas, or ACEs, which is, I believe, your next presentation with Dr. De La Torre. And as you've probably seen throughout today's program, our nurses are amazing. And I'm amazed at how many wonderful suggestions and tips and tricks they can offer. So I would recommend following up with your child's nurses to see if they have any suggestions of how we can make enemas more effective. And most of this program has talked about all of the different treatment options, so I won't go into these in great detail. The one I would like to highlight is transanal irrigation, and there are photos at the bottom of this slide. There are two commercial products in the US that are approved by insurance. That's the Peristeen and the Navina. We find that these are great solutions for patients with spina bifida, as they were designed specifically for patients with neurogenic bowel. There are many different adapters, tools that can be used to have kids be completely independent with their bowel regimen if they have some of the limitations that can be associated with spina bifida. So that might be something for you all to look into as well. As Dr. De La Torre said, diet can certainly play a part in this, but it's not likely to be a fail-safe treatment for constipation. We encourage our spina bifida patients to eat the pea fruits in English, or things like prunes, papayas, peaches, pears, plums, as those can be helpful. I think there's a reason the adage, they say a picture is worth 1,000 words, is true. So I would like to share some photos with you next. So the first is a toddler with spina bifida. We see this patient very often in our clinic. It's someone who I think parents don't think they have constipation because they stool once or twice a day. So this is an x-ray of a 12-month-old who recently transferred care to our center from another center. And as I said, parents were not concerned about constipation and actually had thought that things had gotten better after switching from formula. And as you might see, she has quite a bit of stool in her left colon and into her rectum. So we recommended starting daily Pediallax liquid glycerin suppositories. This is what the packaging looks like in the US. Certainly generic brands are great as well. And then we've had her follow up in 6 months when she was due for her next appointment. And as you might appreciate, her x-ray looks significantly better as there's a lot less stool in her left colon and her rectum. And we recommended that she continue her Pediallax daily and then follow up in 6 months. I know that insurance, unfortunately, does not, at least in the US, does not cover Pediallax. So there are some spina bifida support groups that suggest reusing those, and your child's care team might have other suggestions to make it more affordable, as I know that those can be expensive. Looking at another patient, this is a 15-year-old with spina bifida. And showing you some imaging here. This is the contrast enema. We don't always get a contrast enema in our patients with spina bifida unless they participate in a formal bowel management program, because it doesn't necessarily change the management. And as you might see here, the colon is redundant. There's not much dilation, and it acts like a hypomotor colon that was described earlier today. And then on their x-ray, you can see that they have quite a bit of stool here. And for this particular patient, they were very reluctant to doing enemas, but their reluctance to do so, I think, got in the way of them being a regular teenager. They were missing activities, they were having accidents, not doing things they enjoyed because they were having accidents frequently. So we started them on a bowel regimen of daily enemas with 400 of saline and 50 of glycerin. And as you can see, their x-ray is significantly improved with a lot less stool in the left and in the rectum. They were, however, having leaking with their enema. So this is, and often due to the lack of sphincter control, as we discussed. So we recommended inflating the balloon to 50 mLs and then also elevating their pelvis to take advantage of gravity when they were doing their enemas. And this is a repeat x-ray after making those changes. And as you might appreciate, looks fantastic. So very clean x-ray with no leaking. We know we're very fortunate here at Children's Colorado that we are part of the Spina Bifida Clinic. So certainly we would love to meet you and include you in our clinic and or any of our other bowel management programs, but just wanted to close with a few key points that I think any family can hopefully apply to the care you receive. If this is not the approach that you've used thus far, it's not too late. We think that there's lots of ways and there's no right time or to achieve social continence if that's a goal for your child. We also think there's lots of ways for your child to be independent, and we encourage you to have those conversations with your child and also with their care team, because that's something that's perhaps important to you and to them. We are part of the Spina Bifida Association's clinical care partners, so certainly we think that's a great resource of other clinics that might share a similar philosophy to us. And then we know too, as we've talked about, and I think our psychosocial team will talk later, we having a bowel program that works and remaining continent is important because it affects the child's quality of life. So no, this is something that can be really important on all fronts. And then if your child is having surgeries with urology, it's really important to have conversations about future colorectal surgeries at that same time, as there are some ways that we can combine those surgeries together, which will be covered, I believe, in the next lecture. And then this probably could be a whole lecture in itself, but as your child approaches the age of 18 and perhaps ages out of their clinic, having conversations with their providers about what that transition of care plan looks like is also really important. And I know that was a lot of information in a short amount of time. So certainly thank you for listening and participating. And this is my contact information. So certainly feel free to reach out if you have questions. And I know there's a Q&A at the end, so we can be sure to answer those there.
Thank you so much, Betsy. That was a great lecture. And I don't see any question in the chat. So we're going to move to the next lecture that will be again given by Dr. De La Torre about surgical procedures in a bowel management program. Thank you, Dr. De La Torre. Thank you, Betsy.
Okay, now when we have a patient in our bowel management program, we have to do sometimes surgical procedures, and I'm going to talk about two of them. The question is when the patient need a operation or a surgical procedure in a bowel management program. The answer is very easy. When the patient is doing well and the patient wants to improve their quality of life. And the second one is when the patient is not doing well and requires a surgical procedure. So we already know that all the patients with Hirschsprung, that they lost the anal canal, and I want to show you this image. You can see here the skin, and these little whitish dots is hair, and then this is the anoderm, and then you can see here what we call the anal canal. And the anal canal possesses many nerve endings, so it's a very sensitive area. This is in a normal patient, and the patient with Hirschsprung have a normal anal canal. For any reason, if they lost they have a loss of this area, complete or partially loss of this area, then the patient is going to have fecal incontinence. Patients with idiopathic constipation, that they have like this huge and gigantic rectums. You can see the rectum is reaching the diaphragm. In other words, the thorax. So it occupies all the abdomen. These patients have frequent clinical appointments. The parents call almost every day. The family send message every day. They have at home clean out very frequent. They had multiple admissions in the hospital, in ED for fecal impaction, for nasogastric golightly, etc., etc. I'm talking about this group. When we have these challenging cases, so this patient was born with an anorectal malformation, and now you can see how severe is the constipation. And this patient that we already talked, Betsy, this patient was born without sacrum. This is a patient with a neurogenic bowel. And this patient will be fecal incontinent forever. So what surgery is useful to improve patients' quality of life when they are suffering fecal incontinence? Remember, most of the patients, the majority of the patients with fecal incontinence, they will need enemas, rectal enemas. And because they need these rectal enemas, an AC procedure is a great resource to improve the quality of life of these patients. What is AC? AC stands for A for antegrade, C for continent, and the E for enema. In other words, we are going to create something surgically to give an enema instead from the rectum, from below. We are going to create a connection from the right colon to the abdomen to give the enema in the opposite direction. That's why we call antegrade. And we try to create a valve to make it continent. So the patient is not going to leak, is not going to poop like a colostomy. It's a completely different concept. This is not a colostomy because many patients and families, they believe that an AC is like a colostomy. It's not a colostomy. So in this illustration, you can see, be focused on the left side of the screen. This is the rectal enema. The catheter with the balloon, you give the enema, let's say 250 saline, 20 glycerin, whatever, you fill the colon, then you remove the catheter, they deflate the balloon, and then the patient is going to have a bowel movement. This is a rectal enema. An antegrade enema, antegrade means you are going to give the 250 and 20, 250 saline, 20 glycerin in just one direction, beginning on the right colon. This is antegrade. This could be retrograde, but it's called rectal enema. Continent means that we need to create a valve here. When the patient has the appendix, we can use the appendix and place the appendix in the belly button. And also we call this the appendicostomy. So there are different types of AC procedures. One is the appendicostomy when the patient has the appendix. When the patient does not have appendix, we need to create surgically a new appendix, and the name is neoappendicostomy. Some surgeons prefer just to place the cecum in the abdominal wall and create like a fistula and place a device, and through this device you can do the antegrade enemas. Let me explain you what is appendicostomy. The appendicostomy is, this is the cecum, this is the beginning of the large colon, or the large bowel, I mean. This is the small bowel, and this little small bowel is the appendix. So we fix the cecum in the abdominal wall, and the appendix is just placed in the belly button. This image already was shown by Dr. Bishop. You can see the valve. These stitches create a valve to avoid leakage from the appendicostomy. This is a picture of a patient. The appendicostomy is here. You cannot see it. We try our best to make it cosmetic. Cosmetic means that you cannot see the hole because we have already a scar from birth, and we try to use these folds to hide the opening. This is the same patient now with the catheters. When the patient does not have appendix, we create a flap. Remember, this is the cecum, there is no appendix. This is the small bowel. So 10, 15 centimeters from the cecum, we do a flap. So we cut here, tiki, 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 tiki. So you move the flap, it's on this side again. This is the line that we cut. This is the flap, and this flap is going to be tubularized. We are going to create a conduct. We close the colon here. It's already closed. Now we place a catheter, and over the catheter, we place many sutures to create a new conduct. Now we have a new appendix. The appendix is distal to the original position of the appendix. Now, the next step is to create a valve. So we fold over the new appendix. We avoid to place the new appendix over this suture because you can create a fistula between these sutures and these sutures. So it should be moved away, and then these sutures are going to create the valve, and this is the valve. Now we move the right colon and place it in the belly button. How to access the AC, how the patient is going to give the antegrade enema. To give the antegrade enema, there are three different forms, at least. One is you can place a catheter in the AC, in the little hole, we call the enterostomy, just when you need to do the enema. The other option is to use a mini ACE, which is a device I will show you, or the J tube, which is another device that I will show you. The catheter that we use usually is an 8 French. It's very, very little. You already, I show you some pictures of that. Let's say this is a patient with an AC. The AC is right here, is hidden in the belly button. Now with the catheter. This is the option one. Many patients, they don't want to have something in the belly button. So they insert the catheter, do the enema, and then remove the catheters. The other two options is to place this device. The characteristics of this device is, number one, it has a balloon right here. There are many brands and different types. We call this the mini ACE. And then it has a cap. You open the cap or lift the cap, and you can administer here the enema. And this is the J tube. The difference between the J tube, the main difference is the mini ACE has a balloon, and the J tube has a coil, like a pigtail. So it's going to be holded inside the colon by this pigtail portion of the catheter. It has the same, like a cap, you need to uncap, and then it has a little hole, and you can administer here the antegrade enema. So these are the three different forms. Again, how is the mini ACE and the surface that it touch, and this is the J tube. Is patient preference. The next surgical procedure, which makes me very sad, is the resection of bowel. And this operation is just for patients with idiopathic constipation. So in patients with idiopathic constipation, unfortunately, many of them are very, very sick, or they are using 20 tablets of laxative, 25. They need huge enemas, like 2 liters of saline and 150 of glycerin, and it's very expensive, and they need to do it every day. If they don't do the bowel management, they become fecal impacted very, very, very soon. So in those patients, or when there is no way how to fix the constipation, we can do 2 operations. One of them is the sigmoidectomy, which is just to remove the intra-abdominal portion, the red line. Or the other one is the transanal proximal rectosigmoidectomy. What's the difference between these 2 operations? The difference is, on the left, the sigmoidectomy is just to remove the sigmoid. And we lift the black area, which is the rectum, and little portion of the intra-abdominal sigmoid. In this one, we remove all the sigmoid, and we just leave 5 centimeters of rectum. Why we leave 5 centimeters of rectum? Because we want to preserve the bowel control. This operation is good? Yes, it's good. But this is better. Why is better? Because we left the rectum, and the rectum is very sick. And these patients could have, again, fecal impaction. Again, this is the transanal proximal rectosigmoidectomy that we started to do in 2015, so 10 years ago. And we just leave 5 centimeters of rectum. and we got down from the peritoneal reflection. What's the results of this operation? Well, 88% of the patients and families, they don't call anymore because the problem is already fixed. 69% decrease in clinic visits, but this is the most important. 100% of the patients decrease outpatient or inpatient bowel cleanout. That means they don't have again fecal impaction. They don't have again visits to the emergency department. No more hospitals. No more interventions. All of them have bowel control and they don't have accidents. This is the operation that we are doing in patients with constipation. When we resect these specimens, we did a study to see what is happening in this tissue. This is the control. This is a normal kid without constipation. And this is the patient with constipation. This is the sigmoid. So when you do a sigmoidectomy, you are going to find this fibrosis in the, let's say, in the most inner layer, which is the mucosa, and hypertrophic nerves. But look, in the rectum that you left when you do a sigmoidectomy, the rectum is more hypertrophic, more hypertrophic nerves, and now the fibrosis is not just in the mucosa, also is in the muscular layer. And the fibrosis is something that we call irreversible. So that explains probably why this patient needs too much senna or too much laxatives or high volumes of enemas. When we do this operation, most of these patients, they can reduce more than 90% the amount of senna and enemas. And few of them, they don't need enemas or laxatives. Sometimes we combine these two procedures, the AC and the resection, in patients with constipation, with idiopathic constipation. So sometimes we do the resection and create an AC. Thank you very much. Again, this is my emails if you have any question.
Thank you, Dr. De La Torre. Let me see if there is. What do you do when the tube is blocked for the Malone procedure?
The tube or the conduct? What was the question?
I think the tube.
You
Change the tube.
Remove the tube and clean it out, unclogged.
Perfect. What are the side effects of an appendicostomy?
The side effects, okay, if you are thinking that the patient is going to have appendicitis, no. The appendicostomy usually is a perfect procedure, usually. But I want to say some patients could have leakage that we can fix. Some patients have stenosis or narrowing of the opening, and we need to redo the opening. Some patients can have some bleeding because it's mucosa from the bowel. Is the most common issues with the appendicostomy. No side effects is the most common problems.
And the last question, how do you do the transanal resection leaving 5 centimeters of rectum?
Okay, this operation, to explain, we need to do another course because it's not easy to explain in this conference. Doctor, I don't know, is if a doctor or no? He can email me and I can explain him, or we can have a FaceTime meeting or another Zoom.
Perfect. So we're going to move on just to stay on time. Thank you, Dr. De La Torre. There are many questions in the chat that you want to continue to answer. So it's my pleasure to now invite Dr. Laura Judd-Glossy, who is the psychologist of the International Center for Colorectal and Urogenital Care, and Christina Matkins, who is the social worker for the International Center of Colorectal and Urogenital Care. I think you will all realize that we could not do our work without their help. They are an essential part of our team, and we are so grateful to have them with us. So we are seeing the presenter mode, so maybe you want to, yes, duplicate them. Perfect.
Perfect.
Welcome.
Thank you so much, Dr. Bischoff. Christina and I are so pleased to present with you today, and we're so glad that we can join you. So whether you are a parent or a caregiver, a patient or a provider, we hope to share some ideas about how you can support yourself, your child, or your patient in being successful with bowel management.
Thanks, Laura. We know that fecal incontinence is challenging for everyone. So whether you're a child, an adult, a patient, or a caregiver, it's expected and normal at times that you're going to experience some emotional distress throughout your medical journey and possibly during a bowel regimen course as well. We also know that sometimes patients and caregivers can struggle with a delicate balance of obtaining the support that they may need while also trying to keep private a private medical condition. Research tells us that the longer a patient has incontinence problems, the greater the chance for developing behavioral and emotional problems. So whether you're already on this journey or you're just starting today, it's never too late. We're glad you're here. It's often easy for patients and parents or caregivers to feel isolated and alone when managing a colorectal diagnosis or issues with fecal incontinence. For many reasons, it can be difficult to open up to family and friends about these issues or about a diagnosis that you're managing. Sometimes patients and parents or caregivers may feel a sense of guilt, a sense of shame or embarrassment. They may also worry about how they or their child will be perceived once people know about their condition or issues with incontinence. Adding to that struggle is also the fact that colorectal conditions are what we refer to as an invisible condition. You can't look at somebody and see that they may have a colorectal diagnosis or that they may be struggling with fecal incontinence. So that can therefore create an additional barrier to connecting with other people. Sometimes you may notice someone who may share a similar condition as yours. Maybe your child is in a wheelchair and you note and see another child in a wheelchair. That can provide an opportunity through visual connection to connect with another person who may share a similar experience. And finally, we also know that there is cultural health beliefs that can also impact whether or not a family or a patient decides to reach out to their community, and can also impact the type of treatment they may seek out. Given the challenges that can often occur with colorectal conditions and fecal incontinence, it's not unusual that both patients and caregivers may experience high levels of emotional distress at various times in their medical journey. We also know that relationships with families, peers, the work environment and school environment can be impacted as well. It's not unusual for Laura and myself to hear from children as well as parents and caregivers that they've decided to opt out of social engagements due to fecal incontinence. So for example, they may decide not to attend a birthday party or go to summer camp or on a school field trip. We have even had families reach out stating that they've decided not to pursue a family vacation out of fear that their child will have an accident or parental worry about how their child will manage their condition if they're not there with them. And of course, this can absolutely impact a child or an adult's self-esteem when they're dealing with fecal incontinence. And I think we see this a lot within the school age years, especially if there are accidents occurring at school and a child may be experiencing bullying or teasing from other peers. This can certainly start to impact their self-esteem and their self-image.
Thanks, Christina. So given that we're really focusing on bowel management today, we wanted to spend a little bit of time reviewing some strategies that we have found are successful for patients and families that we've worked with here. So I think the first step is when you're thinking about starting a program, whether it's bowel management or any, new medical treatment, is really talking with your child about what to expect. How you're going to talk to your child about what to expect is really going to depend on their age and or developmental level. Certainly how you explain something to a 3 or 4-year-old would be very different than talking to a teenager about that. And I think it can be helpful to actually start these discussions before you even have that medical visit. So you could kind of start having some of these talks when you're preparing to go to the doctor. So perhaps a few days before, if you were coming to our center before seeing Dr. Bischoff or Dr. De La Torre, or if you're going to another center, you could say something like, we're going to see Dr. So-and-so, we're going to see Dr. D tomorrow to talk about how to help you with pooping. What questions do you have for him? So again, kind of giving that rationale, that understanding of, we're going to go be talking about this. And then also giving the child a chance to ask some questions to both prepare for the visit and think about what they might want to know, what questions they might have within the visit. So during that visit, as part of bowel management, it's important, especially for our parents and caregivers, to think about what information you need to receive in order to support your child, and then also what information your child may need. Christina's going to talk a little bit about some ideas that we have to support parents and caregivers in your approach for this, but there may be times that you have questions that you don't feel comfortable asking in front of your child. And so think about how you can get those questions answered. Is it asking maybe a partner or another caregiver to step out with the child? Is it sending an email afterwards? Because we want to make sure that caregivers feel really comfortable with whatever the medical treatment is going to be. So once the treatment is determined, so in this case, often it might be either an enema program or a laxative program. This is where it's really helpful to think about the best way to share the rationale or the why for the treatment. And again, this is where you can kind of reinforce what you've said before. So it might be something like, remember we went to talk to Dr. D about starting to help you not have accidents and work on pooping? We're going to start a new routine. Again, something pretty simple like that. As I've kind of been mentioning through, it's really important to think about the language that you're using to describe what the medical treatment is. So for example, a child may not know what a catheter is, but they likely understand what a straw is or what a tube is. Similarly, often, our providers or parents may think about what is the enema solution? But to a child, the word solution may not make sense. So you might talk about what's the special water that we're going to use for your enema. And even that idea of an enema, we've had families call it something like wishy-washy time or their treatment. Again, you can think about what is language that's going to make sense to your child. And again, similarly, if your child's starting a laxative treatment, they may not know what a laxative is, but maybe you can talk about it as their poop medicine to help them poop. So some ways that you might talk about this are things like, your body is not able to get the poop out without help when you need to go potty. So we're going to do an enema. An enema is when we use a soft, small tube to put some special water in your bottom to help you poop. Once all the water's in your bottom, you'll sit on the toilet for a little while until all the poop comes out. And then we'll do enemas every day to keep you from having accidents. Since your body keeps making new poop every day, the poop has to come out. Again, so that's maybe a way that I would explain the idea of an enema to a preschooler or an early school age child. Similarly, for a laxative example, you might say something like, you're going to take some special chocolate poop medicine to help the poop come out of your body. When you notice that you need to poop, either me or dad or whoever the caregiver is, or your teacher or whoever it is, can help you find a bathroom to go poop. So again, these are just kind of some simple ways of talking with kids about what to expect. And again, ideally, these discussions, these conversations are happening before your child is first doing an enema or before they're first taking laxatives. So they have an opportunity to really ask questions and kind of understand what to expect. We also have some additional strategies around kind of the logistics, especially with doing enemas, that we wanted to share. So now that you've talked with your child about what to expect, it's good to consider kind of how to support them with the actual enema process. We really think it's so important to think about how you can involve your child. We know that even simple tasks can help support that idea of control and mastery that we know that all children and frankly adults want to have. This could be something like helping with the setup of the enema. So it could be measuring, the glycerin or the saline, dumping it in the bag. A lot of our kids like to shake it around, getting supplies together, thinking like things like that. It also could be thinking about how is the room set up? Are you doing the enema in the bathroom or is it somewhere else? What are some items that your child might want to have in there with them? So could it be a favorite blanket or a stuffy, something that kind of is cozy, as well as some activities to help them do during the enema. And again, especially when you're thinking about making the enema together, like mixing the solution, that's a great opportunity to really talk through what you're doing. Remember, you have two parts that are part of the enema solution, right? Or the special medicine. We've got our glycerin, and then we've got our saline. And so you can talk through that to kind of reinforce that the child knows what you're doing. We know that the work of children is play. Allowing children to touch and play with medical supplies can really be helpful for them and really decrease the fear that sometimes goes along with certain medical equipment. We know that children often use play to express themselves and make a sense of their environment. So we think whenever possible, it's helpful to give kids access to the enema supplies or whatever supplies are for that medical care. So this may involve having a second set of items. You have one item that they can play with, that they can run water through and maybe use in the bathtub or things like that. And then you have another item that maybe you're using and saving for the enema. We've actually seen that many children will kind of give an enema to a doll or a stuffed animal, again, as just a way of making sense of this experience of having an enema themselves. It also can be helpful to really think through what are some activities that may be useful for kids to help them cope and be distracted during the enema time. I think for the majority of our families, they usually use some kind of electronics. And often what we find it's helpful is really pairing the enema time with a special activity, ideally one that maybe they only get to do during enemas. So for example, if this is a kiddo that loves a certain TV show, maybe the enema time is the only time they get to watch that TV show. That's their special time. So in some ways, we're combining what might be a little bit stressful or scary, the enema time, especially as they're getting used to it, with something that they really like and look forward to. The other piece with this is it's helpful to give kids choices. So if you're doing, an enema every day, there may be some days you want to watch your favorite show, but maybe another day you want to use Play-Doh or you want to color or listen to your favorite song or things like that. So anytime that parents can give kids choices is helpful. I think the only thing I always like to state about choices is make sure whatever choices that you give, you're okay with either option. So. And then finally, just thinking about some additional coping strategies in addition to that distraction that can be helpful for kiddos. So this could include something like doing some deep breathing or what we call like belly breathing. Sometimes this is just like putting your hand on your belly and taking a couple deep breaths in and out. With younger kids, sometimes I like to kind of have them pretend, that they're holding a flower in their hand and they can smell the flower and think about what it smells like. And then they can blow out and try and pretend to blow the petals off the flower. So this is just kind of an easy way to model that deep breathing that can be helpful for kids. Sometimes kids like to use things like timers, especially during that dwell time, if they have to wait 5 or 10 minutes, and sometimes that can feel like a long time. Having that timer in the background can be useful so they have that visual of how much time is left. Other kids sometimes really like to be kind of nice and cozy. And so that could be whether it's squeezing their hands and kind of having an alternate sensory experience or having a weighted blanket or something warm and cozy on them. Other kids maybe enjoy listening to music, so a favorite song, things like that. But But I think big picture, we really encourage you to think about what are some choices, what are some ways that we can make, especially the enema experience, more calm and comfortable for the child, so that it is something that they feel comfortable about and know what to expect.
So now we're going to transition to talking about some strategies for support for caregivers. I think one of the best ways we can take care of our children is, as parents or caregivers, is to take care of ourselves. So self-care is really important, and it's critical, as you all know, to maintaining our overall emotional, physical, and mental health. The same is true when starting a bowel management regimen. It can be really stressful thinking about starting something new, how to integrate it into your schedule. For some of our families, starting an enema regimen can feel overwhelming at first as they're starting to learn and understand that process. All of that is very normal. And it's also important at the same time to make sure that you're not only supporting your child, but that you're also supporting yourself through this process as well. Because what we know is that children are very in tune to their caregivers, parents. And so if you're not managing your parental stress or worry, or if they pick up on concerns that you may have about the bowel regimen or apprehension, it can certainly then start to impact not only you as the caregiver, but the child as well. They can begin to internalize and even take on some of those parental worries or caregiver worries themselves. So some of the things that we recommend is, first of all, just knowing that it's incredibly normal to be nervous about starting something new. It's new to you as a parent and to your child. So making sure that you feel as comfortable and confident as possible in the process itself, making sure that you have all your questions answered and not hesitating to ask questions more than one time, because oftentimes parents and caregivers are receiving so much information, it's a lot to take in. So we often expect that parents will ask questions and that we'll want to go over information more than one time with them. Also, if your providers have handouts that they can give you, something that you can take home that walks you through the steps, especially related to an enema, that can be very helpful. Other things we recommend for parents and caregivers is if there are two of you, and for example, and you're going to be doing an enema, deciding who might be most comfortable in administering the enema, and then who might want to be the support person for the child, and also for the parent or caregiver giving the enema. That way you're identifying roles that feel most comfortable for you in that process. We also recommend doing what we call a practice run through, going home and actually physically walking through with materials, setting up the bathroom, everything that you're going to do before administering the enema, so that you can walk through each step with each other, who's going to do what, and what potential challenges may arise, how you might support your child in that moment. And any potential issues that may arise that you can problem solve ahead of time versus in the moment. It's similar to doing like a fire drill, practicing where the exits are. You're doing the same with an enema. You're just practicing the process and the steps prior to your child coming into the bathroom. There also may be moments where one or both caregivers may feel a little bit overwhelmed. Being able to give your partner a nonverbal signal, or even saying, Mom's just going to take a minute to step out and take some deep breaths, and I'll be right back in. It's a great way to model for your child some coping strategies, but also remembering that you're also, in addition to supporting your child, you're also supporting yourself. And just like any regimen, often as time goes on and it becomes more a part of the norm of your daily schedule, those feelings of stress and worry should start to dissipate and start to just be eliminated from that experience for you. And if not, we certainly recommend that you reach out to your team. If they have a psychologist or social worker on the team, accessing them for support for you as the parent or caregiver, or also talking to the provider or team about any additional questions or concerns that you have. And for some families, it may be seeking additional support in the community, which Laura will talk about a little bit later. In regards to the parent-child relationship, I think a caregiver is in such a unique position. to really help your child understand and accept their medical condition. It begins with us as the caregivers and parents. How you talk about their medical condition, including their bowel regimen, and others about it really will impact how the child might perceive their medical condition and their bowel regimen as well. So for example, if a child hears, you are so strong and brave, you're doing such a great job, the child will often reflect and internalize these messages. So maybe at a future time when they might be struggling with their enema, they might recall, wait a second, this is hard. I have been through a lot, but I'm brave and I can do this. I've already done it before. Whereas if we send our child messages or reflect to the child that this is going to be really hard, I'm not sure we're going to be able to do it, or everything is harder for you because of your medical condition, it can lead to the child viewing their world or the bowel regimen as difficult and something that they or their parent is not going to be able to successfully do. And this can certainly impact their ability to persist through a difficult time or a difficult part of their bowel regimen. Many of our children have multiple caregivers that are providing their care at home or in the community. So whether there is one caregiver or many, whether your child lives at one home or splits their time between multiple homes, it's important that everybody who is providing care for the child is knowledgeable about their condition as well as the treatment plan. So this includes the enema regimen or a laxative regimen. If it's going to occur in their home or in the school setting, then you'd want to identify those appropriate people. So there are really three main components we think about with caregiver collaboration. It's important that there is consistent communication, that there's consistency across settings, and that there is coordination in care. So for example, for families where a child may be going between homes, if you're doing an enema, for example, at 7 p.m. at night, and they're at grandma's house during that time tomorrow night, then grandma should be doing the enema at the very same time that it's happening at your home. So if it's 7 o'clock at your home, it should be 7 o'clock at grandma's, at dad's, wherever that child may be during their bowel regimen. The same is true for laxatives. If laxatives are being given at 6 a.m. in the morning, then if they're spending the night at grandma or aunt's house, they also should be giving the enema at 6 a.m. in the morning as well. And then finally, we also know that sometimes communication can be difficult between homes for a variety of reasons. So some parents will choose to share a medical logbook between one another. This is a logbook where you can put down or write down important information that another caregiver might need. So for example, what time did you give the enema? Did it go well? Were there any challenges? If there were, what were some strategies that helped the child or you get through that difficult moment? So some suggestions to help with coping and things of that nature that they may be able to try if they run into the same challenges within their own home. The timing of the enema or the laxative, how did it go while they were stooling on the toilet? Just any critical information that would be helpful. That book then can go in a backpack or in their bag that they'll travel with to the other parent's home or another caregiver's home. For some of our patients and families where there may be a high conflict divorce occurring or parental communication is very high conflict, some of our parents have opted to use a communication application on their phone where they communicate via text or a secured application. Some of our parents use something called Talking Parent. Oftentimes courts here locally will recommend that for parents who are having difficulty communicating or not feeling safe communicating. They can then share important and critical medical information, and that information is then visible to the court as well as to one another and cannot ever be deleted. So it's always there to review and go back to as needed. And finally, in terms of self-care, we know that one of the best ways that, we can take care of ourselves is by establishing a support system. Accessibility to those who share common experiences or can be a good emotional support is critical. So things like family, coworkers, friends, support groups, therapists, your medical team. There's a multitude of ways to create a support system, but we know that that's really critical as you navigate support for yourself and the success of a Bowel Regiment program. And consider siblings. We know that siblings of children with medical needs can sometimes feel left out. They may feel like their brother or sister is getting all of the attention with medical appointments, or wonder why you're going into the bathroom for, a period of time and they're not allowed to go in, or why don't they get the same attention? So it's important, just as you're talking to the patient or the child who has the medical condition about what's happening, also to take the opportunity to talk with brothers and sisters about their siblings' medical condition, as well as Bowel Regiment, of course, in age and developmentally appropriate language. Think about ways that they may be involved in the Bowel Regiment program. Now, this is going to be definitely dependent upon age, developmental level, as well as parental comfort and patient comfort and sibling comfort. So, for example, with our younger kids, we often will see siblings that will carry in supplies or help set the bathroom up. They may even watch a movie or play a game with their sibling while they're on the toilet or during their enema. Of course, if a sibling is not interested in this, or the patient is uncomfortable, or the parent, we want to respect that and not push that issue. But thinking about ways that they can be a part of it. One of the things we also recommend when possible is creating time to spend with siblings one-on-one, where you're just spending an hour with them. Maybe it's weekly, something that's just related to them, not talking about their sibling's medical condition, nothing related to medical care, maybe doing a favorite art activity, going on a walk, just spending time doing something that is really just focused on them. And finally, reminding siblings who they can talk to if they have questions, encouraging them to ask questions and express their feelings. And of course, reminding them that their sibling's medical condition is something that's private, and that as a family, we talk about who is okay to share that information with and who it's not okay to share it with. Many, obviously, of our children are going to be in school for a good portion of their time during the week. And so we really recommend and talk about the importance of coordinating and communicating with their schools so that there is a support system in place to manage their medical needs within the school setting. So that can be identifying whether it's the school nurse, a teacher, an administrator, but someone to talk to about what your child's condition is and how and what they need in order for it to be managed well at school and hopefully minimize disruption to their educational needs as well. So for example, in the United States, and for those children in public schools, there are often two ways to support a child's medical needs specific to colorectal conditions, fecal incontinence, constipation. One of those is if your child already has an individual educational plan, which means that your child has some unique learning needs. You have a plan together to address those unique learning needs. You can actually add medical accommodations into that plan. So for example, for many of our children, one of the accommodations we recommend is access to a bathroom at any time during the day. So we ask that teachers do not have our students wait. If they need to use the bathroom, they're allowed to use it immediately. For some of our older kids, we will include in an accommodation that they identify a nonverbal cue to ask to use the bathroom. Many of our older kids have shared that it can be embarrassing, or they feel like they're drawing attention to themselves if they have to repeatedly ask to use the bathroom. So developing a nonverbal sign to indicate they need to go, and then being able to go as well. If your child does not have an IEP or unique learning needs, then you can request what's called a 504 plan. In the United States, within the public school setting, this is a plan for children who have a qualifying medical condition, which colorectal conditions, constipation, and fecal incontinence qualify. You then can have a document that sets up medical accommodations in the school to support your child. You do have to request this accommodation be established. So oftentimes it's important to get a letter from the medical team that's treating your child to confirm that they have a qualifying diagnosis that's presented to the school, and then a meeting is requested. They usually need to respond to your request within a couple of weeks to get a meeting set up where you can meet with the child's team then to put this, to put the accommodations into place. This stays in place throughout their school career. You can make adjustments and changes to it as needed. Usually they'll review it annually. And finally, we really encourage you, if you're having challenges coordinating or communicating with your school, really maybe identifying some additional supports in the community. There are sometimes educational advocates within communities that can help advocate on behalf of a student with medical needs. They can help mediate conversations between school and parents. Additionally, you may also want to reach out to your medical team. Laura and myself are often coordinating with schools to help them understand the child's medical condition and then the accommodations that would best support them in their school environment.
Thanks, Christina. So I think as caregivers, you know, everyone wants to raise happy and confident children. As Christina mentioned, we know that many of our patients have invisible conditions, and so others may not automatically know that they have a chronic colorectal condition. And while sometimes this could be potentially protective, given the stigma associated with a colorectal condition, it also sometimes can make it more challenging for them to connect with others who have a similar medical condition. So we wanted to kind of talk about a couple ways to really build that confidence in kids. The first idea is really helping support kids and having an age-appropriate understanding of their body, their medical conditions, and what they do to take care of it. So this is really kind of goes along with some of the other strategies I mentioned before. So helping kids to understand the rationale for different medical cares, things like giving them information if they do have a congenital condition that maybe they were born with a part of their body being a little bit different. And so they have some things that they do to take care of it. Again, the idea is thinking about what is the language that you're using to help them understand their body and how to involve them in their medical visits. We know that the more that kids have a good understanding and confidence with their body, it just gives them confidence in who they are overall. Similarly, the idea of meeting others with similar medical conditions is so important. We know that meeting others who truly understand really helps people to not feel alone, whether that is a child or a teenager or an adult. And what we often see when we connect kids who have similar medical conditions is they may not necessarily talk about their medical condition, but there's a certain level of comfort that they have just knowing that that person also does a flush or takes some laxatives or has a similar kind of medical history. I think it's also helpful to highlight kids' areas of strength and interest. So we don't want them to be defined by their medical condition. And we know that their medical condition is just one part of who they are. So this can basically look like talking with kids about what are their interests, what are their strengths, and highlighting what those are and potentially praising them. And then finally, thinking about how we can empower kids to make choices that are appropriate for them. So again, and we've talked a little bit about this, but just to highlight, this could be during the enema process. This could be around what stuffy they want to bring to a medical visit. It can look lots of different ways. Again, thinking about preschoolers, something pretty small. School age kids, you may get them more involved in thinking about what's the time of day that they want to do the enema. Who do they want to share with about some of the medical cares that they do? And thinking all the way through teenage years, how do we help kids be more independent, both in their medical cares and taking the lead in medical visits to, again, give them an increased sense of control and choice, which leads to that increase in confidence. One way that I have found that really builds confidence in kids is knowing how to advocate for themselves. It is very common that kids will come to me or a parent might share that kids are feeling nervous about, you know, what a peer or a classmate might ask them about, or how to answer questions about why they go to the nurse's office or why do they leave the classroom often. And I have found that kind of this brief 3-step process can be really helpful and kind of modified based on the child's age or developmental level, but gives them a good way of feeling like they have an answer to some of those questions. So the first step is really providing some brief information about again, the medical condition or whatever the situation is, then providing some brief reassurance and then redirecting. So for example, if let's say an elementary school child, maybe a classmate is like, why did I see you in the nurse's office yesterday? Or why do you always leave the classroom? The child and the parent could think beforehand about like, what's some information that would feel comfortable sharing with the child? So it could be, oh, I have to take some medicine in the nurse's office, or, oh, I just have this like issue with my stomach, or something like that. And the next step is again, that reassurance, but it's not a big deal. And then that redirection. What do you want to do at recess? Or, oh, did you watch that new show? Or whatever it is that kind of feels comfortable for the child to get the attention off of them and their medical condition and onto something that feels more confident and comfortable to them. What we've also found is if kids practice this at home with a parent or a caregiver, then when the situation arises, whether it's at school or an after-school activity or a sports practice, they feel good in knowing how to answer these questions and feeling confident. So Christina and I have alluded several times to kind of different psychosocial supports. And when you're thinking about potentially approaching bowel management or a bowel management program for your child, it's really helpful to consider what psychosocial supports may be available. So these are some examples of the supports that are available with us at Children's Hospital Colorado. So for example, the opportunity to connect with other kids who have similar medical conditions or to connect the caregivers. Thinking about support groups for either kids or teens or caregivers. An opportunity, again, to meet others and tell a little bit about your story and hear other people's stories. And finally, the chance to meet with myself as a psychologist, Christina as our social worker, or some of our child life specialists. Again, when you're thinking about getting that bowel management support, I would encourage you to ask and think about what might be some ways that you could be connected to other patients and families that are in your local area. If it feels like some of these strategies that we have given maybe are just not enough, and your child is really struggling with whether it's their medical regimen or something else, it may be helpful to think about some additional mental health support. So this could be mental health support to think about increasing the adherence to their daily laxative or enema regimen, or it could be if you're seeing concerns about anxiety or inattention or concerns for autism or medical trauma, lots of different, potential presentations. It could be helpful to try and find a local mental health provider. These are some questions that we think could be useful in you reaching out to find a mental health provider in your area. Have they ever treated a child who's been dealing with incontinence before? Do they use behavioral approaches? Are they willing to collaborate with a medical professional, whether that would be a doctor or a nurse, or maybe another psychosocial provider? And do they have experience in really supporting families with adherence to a medical plan? So certainly finding a colorectal kind of mental health specialist in your area may be challenging, but if you find someone who has had some experience in working with kids with medical conditions or is willing to learn and collaborate, then that person could be a good fit for you or your child. As our time is wrapping up, we did want to share a few other psychosocial supports that are available. Some of these are national or international groups, others are summer camps. So the first one is the Pull-Through Network, which is a group based in the US. That's for kids with different conditions that affect their bowel or bladder. The 1 in 5,000 Foundation is an international group that was started by an adult patient in Australia. There's a number of different Facebook groups. Many of you are likely aware of the ones that Dr. Pena and Bischoff do. That may have been how you've heard about today's event. Dr. D has a YouTube channel. There's also something called the Colorectal Support Network, which is a private group that's run by one of our parents. And then finally, there's a private, kind of hidden adult anorectal malformation group. So if you have interest in that one, feel free to reach out to me and I can connect you with the leader of that group. And then we know that, again, meeting other kids can be so helpful. And summer is often a really helpful time for kids who are school age to be able to get away, maybe go to summer camp. And so there's a program called Youth Rally, which is here in the US, again, for kids who have a condition that affects their bowel or bladder. And then there's something called the Serious Fun Network, which is a series of camps all across the globe. So not just in the US. The camp within Serious Fun that's closest to us is called the Roundup River Ranch, but they do have a number of camps across the US as well as in many, many different countries. So I'd encourage you to kind of look into that. All right. Well, as we're wrapping up our time, we did just want to thank you so much for spending the time with us. If you have questions, please feel free to reach out to us, either to Christina or myself. Our phone number and our emails are here. And we'd be happy to give you some suggestions, help you maybe find a provider in your area, or anything else that we can help with from a psychosocial standpoint.
Thank you, Christina. Thank you, Laura. I think that was amazing. There is one question, and I'm not aware. Are there national organizations or support groups specific for children with constipation?
That's a great question. So I would say all of the resources that we shared for the most part include kids with constipation. So for example, that Facebook group that was started by one of our parents, the Colorectal Support Network, there are members whose kids have anorectal malformations, Hirschsprung, spinal conditions, as well as constipation. So I would think a lot of these conditions would be open to patients and families with more idiopathic constipation as well. I don't know of one that is specific to constipation so I guess I would encourage you to reach out to one of the ones that we shared.
Perfect. Thank you so much. That was great. So now as we approach the end, I know throughout today's lectures, we were able to answer many questions. But if there are any questions that somehow we did not answer, this would be the time to put in the chat and we can try to answer again. Just remembering, we cannot give medical opinion, or we cannot talk about a specific diagnosis without seeing the patient, but generally we can answer most questions. So if there is any question, please type in the chat and we'll try to answer. We'll give 1 minute to see if there is any question. I don't see any questions. Luis, do you see any questions? So the question about recording, yes, we are recording this meeting and we try to share with everyone that have joined the meeting. How do we get Peristeen covered by insurance? That depends on the insurance, but you need to see a physician that would recommend Peristeen to you. From the presentations, how do you go back to enemas if you are already on a laxative? You can go either way. Of course, laxative can only help patients that have bowel control. Enemas are for patients that have fecal incontinence. But if you want to try one way or the other, you have to contact your provider and enroll in a bowel management week. So Pennsylvania, Dr. De La Torre is actually licensed in Pennsylvania, so he can probably do a telehealth and you can go from there.
There is a question if you can show the bag that we use for the rectal enema. I don't have it in my office.
I don't have to. It's a feeding bag. It's the same bag for feeding. That's the one we use. When do you recommend stopping laxatives and trialing enema in young children? Usually around 3 years of age. That's the age that we want patients to be clean. Oh, there's Annie, completely ready, showing the feeding bag. Go ahead, Annie.
So the brand that our hospital carries is called Kangaroo Gravity Feeding Bag. There are many different options. There's one website that we sometimes direct patients to purchase medical supplies outside of like a medical equipment company. It's called discountcatheters.com. And if you search Gravity Feeding Bag, then you'll find several options. One thing to pay attention to is just that the end of the bag has this adapter cone. Sometimes it comes without it, and you can purchase it separately.
Perfect. So ready.
Oh,
yes.
I also just wanted to add a point about the Peristeen. If you're trying to get Peristeen covered by insurance, you can work with your provider to make the language in in the consult note strongly recommending the Peristeen rather than the patient would like to try. I think that's something we've noticed recently in the kickbacks from insurance, is to say the patient has tried and failed these other modalities. And so I strongly recommend the Peristeen, and that's been more successful.
There is one comment, I don't know if it's a doctor or a patient, that it's planning to visit the United States and would love to visit our center. If it's a patient, send an email stating what is your main problem. If it's a doctor, state when you want to come, send us an email. It's a doctor. So we'll be happy to have you. There is some paperwork that needs to be done before your arrival. Do you admit patients when they are on a trial for enemas? We do not. It's a 1-week intensive program, but it's as an outpatient program. The Dr. De La Torre, they are asking for your email since you are licensed in Pennsylvania and how they can contact you.
Where is that?
Ariana. So I think
In
during
the webinar
all
chat or in the Q&A?
in the chat. So
I
during
think
all
another
of
thing
our,
to
go ahead.
Go ahead. I just wanted to say another thing to consider. I think the question was about Pennsylvania Medicaid, and to enroll in a program in out of state when you have a different state's Medicaid, it can be challenging to get approval. You start with your primary care provider and submit a letter to offer that kind of care, and we can help support with letters of medical necessity. But I think even with Dr. De La Torre being licensed in Pennsylvania, if the program is through Colorado, there still would need to be some process to get covered by Medicaid.
Dr. De La Torre, do you want to answer why gastroenterologists all over the world are afraid of Senna? And why do they prefer PEG?
They don't know the SENA, and the polyethylene glycol was created by a lab that support many GIs, is my personal opinion.
Question about fiber.
It looks like it was about the insoluble versus it's a little bit water soluble and insoluble. And what's the instances? Did you see it? Looks like it's Courtney Allen.
Yes, I don't remember the type of fiber, but we use Benefiber because we want to give bulk to stool. The advantage of Benefiber is that it has no flavor, so it's easier to mix in any drink, and patients usually accept it. Okay, I think we answered. How soon after a PSARP surgery should an infant be assessed for fecal load or bowel management? That's a great question. So we have our routine. If the patient had a colostomy, once we close the colostomy, we get an X-ray 10 days, 1 month, 3 months, 6 months, and then every year to monitor for constipation. If the patient doesn't have a colostomy, same thing. 1 month, 3 months, 6 months, and every year. Usually constipation will show up at the moment that solid food is started. Wonderful. Okay, I think we answered most of the questions. If not, please reach out. Our team here is happy to help you. I would ask Ray, the man behind all the work, to show up in camera, because without him, this would not be possible. There is Ray, who makes everything work. I would like to thank our interpreters too. I'm sure many of our families appreciate having Spanish interpretation, live Spanish interpretation. And we look forward to hear your suggestions. What would you like the next webinar to focus on? And count on us to help you in anything we can in your patients, in your child, in yourself. So on behalf of the entire team, we thank you so much for being here with us today. Bye-bye.
Bye. Thank you.